We went to the panel. Dr. Ajit Sood is here, who's a very experienced IBD physician in India, and Dr. Devendra Desai is also here. So, hi everyone. Dr. Ed Loftus is a professor at Mayo and was my professor, and I learned a lot from him during my IBD clinics. And Deepak was my co-fellow. Right. So he was extremely interested in IBD, and he has followed his desires, and he's an assistant professor at WashU now. So he's doing a lot of good work in IBD. So yeah.
Yes, sir.
Thanks, Saurabh.
Yeah.
And a lot of Mayo connections for your future speakers there.
Yeah, I had the Cornell people initially there. Now there are a lot of Mayo people now. So one second, yeah. So good. So all things back in Rochester, I think settling in terms of COVID. I guess things are much better.
Yeah, I mean, I was probably in the first or second wave of, I guess the second wave of vaccination. So I got vaccinated back in January, and it's really basically gone, and all the restrictions are essentially lifted in Minnesota right
now. Yeah.
Any guess, Edward, about the third wave in US or in India?
Yeah, I would say in terms of the percentage of vaccinations, I think about half of all the people have half of the adults have been vaccinated, and it's very political. It's like depends on if you were a Trump supporter, you basically aren't getting vaccinated. It's really weird how it's like there's two alternate universes about vaccination in the US. It's just very strange.
Yeah. Right. You know, in India, people say the third wave is expected in about 4 to 6 weeks' time.
Oh, really?
Everybody is on the move now. People say enjoy holiday till the time we have a third wave.
Yeah. Are people, is there access to vaccines now and all that?
Yes, we have access now, but problem is that everybody still doesn't go for a vaccine.
Yeah.
And it's such a big country, it's not really possible to vaccinate the whole country in a short time.
Right. Yeah, I heard, because some of my colleagues who are from India talking about their families, like everyone, being locked down for quite some time. So the lockdowns are over now? Is that correct?
Practically, yes, at least in North India.
Okay.
It's quite free at the moment.
Good.
That's what I said, that people really want to enjoy next couple of weeks, and they hope there is a fear that third wave will come, but that is life. We can't really remain restricted for a very, very long time.
Yeah.
So Ed, living in Missouri, I guess, who knows, maybe we'll get a third wave.
You could, I think. It's very possible.
Yeah, pretty much people in clinic are either divided into those who have been vaccinated and those who will not get vaccinated.
Yeah.
So there's literally no one in between unless they're below the age of 12, or I guess maybe below the age of 18. So it's shocking how like the urban areas are so different from the rural areas.
Yeah.
But you know how that goes in terms of political leanings. So
yeah, for sure. I had one patient. The husband of the patient was telling me, "Why do I have to wear this mask?" This is like during the peak of our last wave. And I said, "Hey, buddy, there are 100 people in the ICU just a mile down the road." So, it's crazy.
My concern is that we got vaccinated in January. Now it's nearly 6 months.
Oh, yeah.
If there is a third wave, even people who are vaccinated in the initial months may not be protected.
Yeah, we're not sure.
Okay.
Yep.
So I will, I think we can just start with the introductions, because from my past experiences, it ends up being longer than I planned the event. So I'll just, I feel like we can start at least the introductions, and then we can start with the talk. My father is here, Dr. Shrikant Mukewar. Dr. Loftus, just wanted to introduce.
Yeah.
Deepak,
Hi.
He knows.
Hello.
Welcome, Dr. Loftus, and
Thank
welcome,
you.
Deepak, for this webinar. Ajit, I could see Ajit. I had an interaction with GV just now. And Devendra, has he joined?
Yeah, he's there.
Hi.
Hi, Devendra. Hi.
Good evening.
Good evening. Good evening, everyone.
Yeah, thank you.
Please.
Thank you for hosting us. And yeah, I guess I've met you in person, I guess, when you were visiting Saurabh quite a few years ago. Yeah.
Okay.
Great,
I think
great.
if okay with everyone, we can start with the introductions and then take it from there. If you want to sort of start, I can introduce everyone.
No, you can just go ahead. Actually, no problems.
Okay, thank you. Okay, so hi, good evening, everyone. I'm Saurabh Mukewar. We've been doing a lot of these events, and we welcomed you to our next event, which is today on management of inflammatory bowel disease. And we have very eminent speakers and chairpersons today who have spared their valuable time. So thank you, everyone. And I'll start with the introductions. To begin with, we have Dr. Edward Loftus, who is a gastroenterologist with extensive experience as a lecturer and clinician researcher in the field of inflammatory bowel diseases. He's published over 400 original articles, book chapters, or editorials, and more than 600 abstracts. He previously served as an associate editor of both the AJG Red Journal and Inflammatory Bowel Disease Journal. He's been the principal investigator on several funded studies focused on epidemiology and natural history of IBD, and has served as a local PI of multiple clinical trials. Amongst Professor Loftus's awards are the Mayo Department of Medicine Laureate Award and the CCFA Minnesota Dakota's Chapter Award, Physician of the Year, AGS Distinguished Clinician Award, IMIBD Sections Research Mentor Award. He's currently the Professor of Medicine at Mayo Clinic, and I had the honor and privilege of training with him and interacted and learning a lot about IBD during my time, and I owe that to him. And thank you so much, Dr. Loftus, for sparing a Sunday morning for us. Believe me, he has a very long CV, so I read all your 147 pages of your CV, so thank you. It's highly impressive. All right, and then we have my very dear friend and colleague, Dr. Deepak Parakal, who is a young enthusiastic gastroenterologist with an interest in the field of IBD. He's an assistant professor at Washington University in St. Louis. He has completed his fellowship training in gastroenterology, a master's in clinical and translational science, and advanced fellowship training in IBD at Mayo Clinic, Rochester. His research interests are centered around non-invasive tools, including CT, MRI, and biomarkers in assessment of transmural disease activity, response to medical therapy in Crohn's disease, and metabolic syndrome. His research is funded through the ACG, the AGA, the Mallinckrodt Institute of Radiology. He's also associate editor for the Crohn's and Colitis 360 Journal of the CCFA. Recently, he's actually published an important study on COVID vaccination and IBD, which I believe Deepak is going to be published in the Annals of Internal Medicine as well. So thank you, Deepak, for sparing time today. It's great to have you. And we have very eminent chairpersons and panelists for today. Dr. Devendra Desai is joining us from Mumbai. He is a consultant gastroenterologist with a vast experience in IBD from Hinduja Hospital in Mumbai, with 146 publications and 23 awards to his name. We have Dr. Ajit Sood, who's a professor and head of Department for Gastroenterology at the Anand Medical College in Ludhiana. He again is a very senior, experienced doctor in managing IBD. He's published more than 175 papers, and he's the founding secretary of the Indian Society for Crohn's and Colitis. And we have Dr. G.V. Rao, who we've been known for a long time as well. And he's a very eminent surgeon. Probably doesn't need any introduction. He's from Asian Institute of Gastroenterology in Hyderabad and has vast experience in gastrointestinal surgeries, including inflammatory bowel disease surgeries. So I thank all of you to be here. And without any further ado, we'll just have Dr. Loftus talk about management of ulcerative colitis and Crohn's disease in 2021. I'll stop sharing my screen. Okay. So Dr. Loftus, over to you, please. Thank you.
Thanks, Saurabh. It's good to see you again. Can you see my slides?
Yes, we can.
Yeah.
Thank you.
Okay, perfect. Okay, so I'm going to talk about ulcerative colitis. Here are my disclosures. This is a complicated disease, a multifactorial disease, an interaction between genetics, the immune system, and presumably luminal antigens, including bacteria. There are multiple inflammatory targets, and we'll touch on some of those today. And you'll notice that the talk is a little bit focused on biologics, but I think it's important for us to remember that in ulcerative colitis, at least, we have several non-biologic options, if you will. So for the patient that presents with mild symptoms, of course, let's not forget about mesalamine. And for proctitis, there are topical mesalamine preparations. And for more extensive colitis, we have the oral delayed release preparations. There's also sulfasalazine as an option. I'm not going to really focus on those today, but those are obviously important to consider. Certainly, if a patient presents with moderate or severe symptoms, we're going to give them a tapering course of corticosteroids. And I think the key here is that steroids are a reasonable induction therapy, but they're not a maintenance therapy because the risk of side effects with prolonged steroid use is essentially 100%. And so we want to avoid those long-term side effects if possible. In the US, I have to say we don't do a lot of azathioprine monotherapy for steroid-dependent or steroid refractory patients, but I think in places where access to biologics are not quite as good, I think that going as a next step in a steroid-dependent patient to azathioprine is actually quite reasonable. And I'm not going to go into all the details of azathioprine use, and I think there are probably some differences in how to dose it. I think the new development over the past 5 or 6 years has been the increasing recognition about the importance of NUDT15 mutations in causing leukopenia. This was first described in Korea by our colleague Professor Yang at the Asan Medical Center, and this finding has been replicated in multiple populations, including South Asian populations. And you all probably know more about this than I do, because I think the prevalence in the U.S. is low enough where we're not routinely checking this. Certainly, we're doing a TPMT oftentimes before starting azathioprine. In Asian or Hispanic patients, I will also check the NUDT15 mutation because it's a powerful cause of leukopenia. In fact, I think in Asian populations, the NUDT15 mutation is more common than the TPMT mutation. So it brings back some memories, vividly having arguments with some of the visiting Korean physicians about why they weren't more aggressively dosing thiopurines. And then when this paper came out, I realized, aha, this is why, they do this, because the leukopenia is an issue. So I think it's reasonable to start, if you don't have access to NUDT15, is maybe start at a lower dose as opposed to the typical, 1.5 to 2.5 milligrams per kilogram body weight. Okay, I'm going to get right into some of the biologics. The first one I'm going to talk about is vedolizumab. And as you know, vedolizumab is a monoclonal antibody directed against alpha-4 beta-7 integrin. The ligand of that is MAdCAM1, which is expressed preferentially on the endothelial cells in the gut. So it's a relatively gut selective. I'm not going to present all the pivotal trials from the Gemini trials. This drug is approved for both Crohn's disease and ulcerative colitis. The new development was the development of a subcutaneous formulation of this, and the Visible 1 trial looked at this in ulcerative colitis. Visible 2 is the sub-Q in Crohn's disease. Sorry, I'm going to go back here. And so Visible 1 basically showed that both the sub-Q formulation was equivalent to the IV. So in this particular trial, patients got 2 doses of open label IV for induction, and then they were randomized to either placebo or Vito IV or Vito sub-Q. And you can see that the sub-Q formulation was equivalent with respect to clinical remission and also endoscopic improvement. Sorry, sorry, I have to turn off that. Hold on. I'm just gonna pause here and take out this audio, which I didn't realize was embedded in. My apologies. Okay, let me go back. So part of the so that was the new development in vedolizumab, and we're going to talk a little bit about the varsity trial here in a second. But there is some issues about positionings of drugs here. Okay, here's varsity. This was a trial. It was a head-to-head trial of adalimumab versus vedolizumab in mostly bio-naive patients. There was a small percentage of patients who could have been exposed to infliximab prior to this trial. And this was a treat straight through design. There was no dose escalation permitted. So that's been one of the criticisms of the trial, because oftentimes adalimumab is dose escalated in ulcerative colitis, and sometimes vedolizumab is too. But at the end of the day, in this trial, the percentage of patients in clinical remission at week 52 was slightly better in favor of vedolizumab. And you can see that primarily this was driven by the anti-TNF naive subgroup, which again took up about 75 to 80% of the patients in the trial. And it was not statistically significant in the small number of patients who were TNF exposed. And then for mucosal healing, similar results were seen. This is one of the key secondary endpoints. And you can see that this was also in favor of vedolizumab. And again, the results were largely driven by the anti-TNF naive subgroup. The one part of the varsity results that was not consistent with the rest of the results was the steroid-free remission, which was actually numerically, but not statistically, in favor of adalimumab. However, at the end of the trial, the median or mean doses of steroids at the end of the trial were somewhat lower in the vedolizumab group. So that was the one part of it that wasn't consistent. But you'll see that for histologic activity, whether this was measured by the Gabos score or the Robarts histopathologic index, you can see that both of these were in favor of vedolizumab. And then similarly, if you looked at the partial Mayo Clinic score for clinical response, this was also consistently in favor of vedolizumab almost at every time point. And you can see that the results were separating by as early as week 6, and certainly were significant at week 14. And so in the totality of the trial, and again, there are some weaknesses to this first head-to-head trial of biologics, the totality suggested that vedolizumab was superior to adalimumab. Now, before I go into other drugs, I want to go back and just talk, because these were slightly out of order. I wanted to talk about 2 other interesting studies. So this one was a retrospective study out of Europe. I believe it was France, or it may have been a Jetate study. This was not a randomized study. This was an observational study looking at patients who had failed one anti-TNF, and then they compared patients that were then treated with either infliximab or vedolizumab. So they had failed an injectable anti-TNF, either adalimumab or golimumab, and then they measured their response. And you can see that For the short-term response at 14 weeks, the vedolizumab patients did a little bit better, roughly 50% versus 26% in the infliximab group. And then when you looked out to 4 years, looked at time on drug, so treatment persistence, you could argue, is a proxy for both effectiveness and safety, right? Because the patients continue on drug if they're doing well and they're not having side effects. And you can see that that was also in favor of vedolizumab. So survival free of basically staying on drug was better in the vedolizumab group. And so again, the major caveat here is that this is not a randomized study. This was a head-to-head study. They tried to adjust for confounders. Even after adjusting, the infliximab treated patients were a little bit more severe. So we have to take the results with a grain of salt, but I thought this was an interesting study. The other, hold on a second here. I have to take out this silly thing here. So this was an interesting study. This was presented at UEGW last year, and this was a French study. And this group from France has done a lot of really cool studies, safety studies with this large French national database, but they actually took the French database and combined it with 2 US commercial claims databases, and they looked for serious infections, which were defined as infections requiring hospitalizations. And what they showed was, so those numbers are actually odds ratios comparing the risk of serious, or maybe hazard ratios, comparing the risk of serious infections with vedolizumab versus anti-TNF. And you can see that for Crohn's disease, they were basically equivalent, but for ulcerative colitis, the risk of serious infections was in fact lower with vedolizumab compared to anti-TNF. So I don't have an explanation of why there was a difference between Crohn's and UC, but I thought that was an interesting paper. All right, so we're going to fast forward. So what else is new about anti-integrins? I've included several slides about etrolizumab. So etrolizumab is a monoclonal antibody to the beta-7 subunit of integrin. So this actually blocks both alpha-4 beta-7 and something called alpha-E beta-7, which is the ligand of that is E-cadherin. So theoretically, this might have a slightly different mechanism of action and slight differences in efficacy and safety. If you recall, about 5 or 6 years ago, there was a phase 2 study showing that etrolizumab worked in UC, and then the manufacturer embarked on this massive development program where they did all these trials at the same time. This was one of the trials, the Laurel study, and this was looking at etrolizumab compared to placebo in TNF naive patients. And basically this was, even though there were hints of a difference, the primary endpoint was not met. The delta between the two was not significant enough. So again, there were trends of effectiveness, but it was a negative study. And then here was a different population, a different trial looking at anti-TNF exposed patients. And this was the induction trial. So the primary endpoint in this trial was met, but then in the follow-up of this trial, which was the maintenance endpoint at week 66, it was not met. So all of these papers were presented at UEGW last year. They also did an interesting 2 induction trials comparing etrolizumab to both placebo and adalimumab. And in one of the trials, the placebo endpoint compared to placebo was met, but in the other trial was not met. And then when they pulled the 2 results together to look at it compared to adalimumab, it was not met as well. So again, you're getting the sense here that there's mixed results with etrolizumab. And similarly, they did a head-to-head against infliximab, and the primary endpoint was not met, which was clinical remission at week 10 and at week 54. And you can see that they were basically identical. So they couldn't prove, I mean, it was great that it was identical to infliximab, but they couldn't show superiority. So basically, etrolizumab is on hold for UC. Stay tuned though, because there is a large study that's wrapping up in Crohn's disease. And so sometime next year, we'll hear the results about the Crohn's disease trial for etrolizumab. So that'll be interesting. There's another anti-integrin that's out there, that's the development of which is on hold. We were involved in this trial. This is an injectable alpha-4 beta-7 antagonist called abrilimab, or AMG 181. And you can see that at some of the higher doses of abrilimab, this was statistically significant against placebo for the primary endpoint, which was clinical remission, the standard definition using the Mayo score. And so whether or not this ever sees the light of day, they were hoping they were going to be better than vedolizumab, and they're early, just looking at these results, they weren't sure they were going to be any different. So it's been on hold, but it might come back. And so we'll see. They also did a Crohn's trial in phase 2. They probably didn't dose high enough, and that trial was negative. And then there is an anti-MAdCAM antibody out there that has kind of shifted around to different companies because of mergers and acquisitions and all that. But this also has a signal for efficacy. You can see that some of the middle doses actually seem to work. And currently, I don't know what the status of this drug is, but it may also at some point see the light of day. I'm going to shift gears and talk a little bit about about ustekinumab and the anti-IL-23s. And I understand that ustekinumab is not approved in India yet, but it may be worth just briefly discussing it. This is a drug now, we've had it approved for Crohn's disease for about 5 years, and for UC for 2 years, I think. So this was the unified trial in UC. I'm not going to talk about the Crohn's results. And this was a large trial. 50% were bioexposed. And this is looking at the induction results. So the induction was basically a weight-based dose of approximately 6 milligrams per kilogram. They had another dose as well. And you can see that the primary endpoint of clinical remission at week 8 was met. And for some of these secondary endpoints, it was also met. I left out the p-values, but these were all statistically significant versus placebo. And it's a pretty well-tolerated drug. I mean, one of the nice things about ustekinumab is that we just don't see a lot of adverse events. And I would argue that in terms of safety profile, it's kind of equivalent to vedolizumab in terms of its overall safety. We just don't have to stop the medication a lot for side effects. And I am going to take out my little audio thing here, which is annoying. Okay, so I want to go back and just point something out to you. So we talked about ustekinumab. This is an antibody against the P40 subunit, which is found in both IL-12 and IL-23. So these other antibodies, which are pure IL-23, are directed against the P19, which is the other component of the IL-23 cytokine. And so there are a whole host of these drugs that are being developed. In fact, there's a fifth one called tildrakizumab, which is, I believe, used in psoriasis. So lots of these drugs around. For most of these drugs, they're further along in Crohn's than they are in UC, with one exception. And I'm going to talk about mirikizumab, which is the exception. So the manufacturer of mirikizumab decided to study UC before Crohn's. So this could very well be the first anti-IL-23 to the market for ulcerative colitis. In Crohn's disease, it's probably going to be risankizumab. But for ulcerative colitis, it'll be mirikizumab. And so this was the phase 2 trial. This was published last year in gastroenterology. And you can see like the middle dose was effective. Actually, several of the doses were effective compared to placebo. Also very well tolerated, not a lot of side effects. This is basically the same trial, just showing some of they did a pseudo maintenance study. There really wasn't a placebo arm in the maintenance study, but they also showed some efficacy as well for endoscopic remission and for clinical remission. So we're going to hear more about mirikizumab in the near future. I wanted to shift gears and talk about the JAK inhibitors, and we'll talk mostly about tofacitinib, but we'll also talk about some of the new players. If you recall, the JAKs they're part of the mediation between the receptors on the cell surface and the nucleus of the cell. So there's the JAK-STAT pathway, sort of sending the signal to the nucleus about which genes to transcribe. And different JAKs are associated, different combinations of JAKs are associated with different cytokines. And so there's still debate about whether some of the differences in how the JAKs block the individual JAKs, whether or not that will translate into differences in efficacy and safety. And I think they do, but we need to see more clinical data to know this for sure. So let's talk about tofacitinib, which is the first one that was approved for ulcerative colitis. If you recall, there were two massive phase 3 induction trials that were done. In both of these induction trials, they were basically identical in design. In both of these induction trials, there was a delta of anywhere from 10 to 13%. And one of the interesting things is the results were similar despite whether or not the patients were exposed to biologics in the past. Patients improved rapidly. The infections were higher in the patients treated with tofacitinib, and we'll get back to that in a second. Here's clinical response on the left, and then clinical remission on the right, stratified by anti-TNF status. And you can see that the results were higher in the anti-TNF naive, but they were also significantly different than placebo in the anti-TNF exposed patients. And then when you took the patients who responded in the two induction studies, and then they were re-randomized to either placebo or 2 doses of tofacitinib, you can see that both doses were significantly better than placebo for clinical response, remission, sustained mucosal healing, and sustained steroid-free remission at 52 weeks. And so this drug has been approved in the US now for about 3 years for ulcerative colitis. I think one of the things about tofacitinib that probably has restricted its more widespread use are some of the safety warnings. It's got a black box warning about infection and malignancy. Now, in the UC trials, the infections, any infections, this includes non-serious infections, were higher than placebo in the tofacitinib arms, but serious infections right below that were identical. However, at the higher dose of tofacitinib, you can see that there was a zoster risk. And so for many of our patients, we when we're counseling patients about the side effect profile, what I usually say, it's like an anti-TNF, there's like an extra zoster risk. We can mitigate that with the zoster vaccine. We can almost always get that in somebody over the age of 50 because it's approved for that in the US. But for some of the younger patients, sometimes it's a little bit of a struggle to get that approved. There are some changes in the lipid profile, but generally the ratio of the HDL to the LDL stays the same, and so it's not clear that that actually translates into a different risk. I don't have specific slides on this, but there's a whole ongoing issue about the FDA issuing a warning about thromboembolism. However, that was based on a rheumatoid arthritis trial in patients who were over the age of 50 with cardiovascular risk factors, and whether or not that risk translates into a risk in our younger UC patients with fewer comorbidities is not at all clear. But again, I think you have to counsel patients on that risk. I'm going to save it for the cases, but there's also possibly a role for tofacitinib as a treatment in acute severe colitis patients. But I think we'll talk about it in some of the cases, so we'll get back to that. So what are the new kids on the block for the JAKs? So there are two drugs that are selective JAK1 inhibitors, filgotinib and upadacitinib. These drugs, the thinking is that if you're not blocking JAK2, you may be able to get away with higher doses of the JAK1 inhibition. In other words, increase efficacy without compromising safety. Whether or not that actually translates in real life to differences, it's not yet clear, but there are some hints that it might. So the filgotinib trial, this was the first big phase 3 trial. This is looking at UC, and you can see the week 10 induction results. Overall, there were actually 2 induction trials, one in a biologic naive cohort and one in a biologic experienced cohort. And you can see that the 200 milligram dose was clearly effective, but the 100 milligram dose wasn't effective for induction. And then on the right-hand side, I'm showing you the maintenance data where they actually randomized the responders to either placebo or the dose that they were on in induction. So the patients that were on 100 milligrams induction got 100 milligrams in maintenance. The patients in 200 milligrams induction got 200 milligrams in maintenance. And you can see that the 200 milligram dose was clearly efficacious. There was also a signal for the 100 milligram dose. This was presented at UEGW last year. I think it was presented again at DDW. And the paper now is online early in the Lancet. And so you can see that study. And then this is just another one of the endpoints, which was steroid-free clinical remission, showing that it was effective for steroid. So at least 6 months of steroid-free clinical remission. This is the week 52 data. And you can see again that the 200 milligram dose is more robust than the 100 milligram dose. What about adverse events? This is looking at the various adverse events. You can see that the serious adverse events, or SAE, is about the same. Discontinuation due to adverse events is about the same. Zoster is down there on adverse events of interest, and you can see maybe a little bit of zoster, but this is just the induction results, but not a lot. And then you can see that there was 1 pulmonary embolism and no DVTs. And then when you look at the maintenance dose, kind of a similar findings. The SAE rate is fairly low. The discontinuation due to adverse events is fairly low. Serious infections are low. Again, not much of a signal for zoster. So this does provide a hint that maybe the safety profile of filgotinib is different than tofacitinib. There were 2 DVTs, but they were in the placebo-treated patients, so not a DVT signal either. And so what about the other JAK1, upadacitinib? So let me go back. The one thing I want to say about filgotinib is it's actually approved in the EU for rheumatoid arthritis. It did not get approved by the FDA because the FDA wants them to finish studies on testicular safety. So there was a preclinical, so in some lab animals, there was a concern about the sperm quality. And so they're mandated to do a testicular safety study in the US. And that is, I think, almost completed. So we should see results of that soon. So until that issue is resolved, it's not going to get approved for ulcerative colitis in the US either. So stay tuned on that. Upadacitinib does not have the issues with the testicular safety. This was the phase 2 trial in ulcerative colitis, and this is actually a paper in Gastro last year. And you can see that some of the higher doses, this was significant against placebo. One of the things they have upadacitinib trials did in phase 3, which I'll show you in a second, is they gave much higher doses in induction. And again, it speaks to the fact that with JAK1, you might be able to drive up the doses higher without causing safety issues. And so in the phase 3 studies, we don't actually have the presentations yet. These are going to be, I think, presented at ECHO, but based on press releases by the manufacturer, you can see the 2 phase 3 induction trials were actually quite significant, massively significant, actually. And so in both of these trials, a 45 milligram dose of upadacitinib was studied, and it looked good for all the endpoints. So stay tuned. We're going to hear more about this. And again, no issues with testicular safety. So I suspect we may, this is a drug that could be approved in the US maybe sometime late next year, so 2022. And then another interesting JAK is this gut restricted JAK. So this is a pan JAK, but it doesn't leave the gut. And so this was the phase 1 study. And again, it's not much data, but it looked very promising. And so this study, this drug has been looked at in phase 2. We don't have the results yet, but this will be an interesting study because the idea is that it's going to work on the gut, the inflamed gut, but it's not going to be absorbed. And so it's going to have a much wider therapeutic window maybe than some of the other JAKs. And then the last class of medications that I wanted to talk about were the sphingosine 1-phosphate receptor modulators. And so this sphingosine phosphate, there's a gradient of this that allows lymphocytes to move outside of lymph nodes. And if you block these receptors, you lose the gradient, and then the lymphocyte doesn't leave the lymph node, and it doesn't get out to the to the blood vessels in the gut. And so the thinking is that this may be a good way to tamp down inflammation. And in fact, some of you may recall this paper. It was in the New England 5 years ago. This was the phase 2 showing that it was effective against placebo for both remission, response, and mucosal healing. And this was the week 32 results, also looking fairly promising, especially the higher dose. And now we have etrasimod, which is another sphingosine 1-phosphate receptor modulator. And this was a phase 2 that also looked promising. I'm not going to go through all the data here, but there was definitely a signal. And this was just looking at that same trial in a different way, but you can see that it was clearly better than placebo, especially the 2 milligram dose, the higher dose. And then at UEGW last year, we got the results of the True North study, which was the UC phase 3 trial. And this also showed significance, especially for response improvement, mucosal healing. This is stratifying the results by whether or not patients had been anti-TNF exposed, but also a positive study. And the maintenance also looked very promising. And so this drug actually just got approved for ulcerative colitis in the US about 2 weeks ago. And so this is a drug that looks promising. So it's an oral drug. So it's a small molecule, no issues with immunogenicity or having to do TDM or anything like that. And I think one of the interesting things about this drug is that it has a very long half-life, the metabolites do. And so I feel like it's a drug that it's kind of initially maybe slow to get going, but if you are a responder, you tend to be a responder for a long time because it has such a long half-life. Here's the adverse event profile. They saw a little bit of LFT issues, but it looked like a pretty safe drug. There has been it's already approved for multiple sclerosis, and there has been in multiple sclerosis, one patient reported with PML or progressive multifocal leukoencephalopathy, but it's one patient, somebody who'd been on the drug for 4 years. And so we need a little bit more data before, to understand the risk of that. So I'm going to wrap up here and just say the future is bright There's lots of drugs out there. We talked about the anti-integrins. There are these, there's tofacitinib, the JAK1 antagonists on the way, as well as ozanimod on the way. So the future is bright for multiple agents. And I'm going to stop there, and I'm happy to take questions. And Saurabh, I don't know if you want me to, if you want to do the questions now or afterwards.
What we could do is we can do a couple of questions related to UC right now. We can have the panelists also weigh in, and then we could switch to a case, and then follow it up with Deepak's talk. Yeah. So there's a question from the panelists here. Is there any role of prophylactic acyclovir when starting tofacitinib? By Dr. Rajendra Patel.
I'm not that I'm aware of. It's not something that I've done. I mean, I think one of the reassuring things about so 90% of the zoster cases that occurred in the clinical trial in the open label extension were not serious zoster. I'm not trying to minimize zoster because, we all know about how painful the postherpetic neuralgia can be. But the good news was that it wasn't, it was not, only 10% of them were serious. So, but I'm not aware of any studies looking at prophylactic acyclovir.
Okay.
Dr. Loftus, excellent presentation and a very good overview of the entire subject. I'd like to ask you, in biologically exposed people, if they are not responded, what is the best drug? Because it was shown that Ustekinumab versus tofacitinib, Ustekinumab in a network meta-analysis has shown to be better as compared to tofacitinib. So what is your view on that?
Yeah, it's a good question. I think, yeah, you're referring to, right, the network meta-analyses that I think it came out of Sid Singh and Bill Sanborn did this. It was and they looked specifically at patients who were bio-exposed. So they excluded the bio-naive patient. When they looked at the clinical trials there, the trials with the biggest effect sizes were the Ustekinumab and the tofacitinib trials. And so that would be the rationale for going with maybe those in a bio-exposed patient. And in my clinical experience, I just don't, yeah, that's what the trial showed. I'm always a little hesitant to make major changes in my treatment position just based on network meta-analyses. So it would be nice to actually see better data. I do think tofacitinib is a very potent, powerful drug. And so I think that is a reasonable place to start for a biofailure patient. In fact, in the US now it's restricted to biofailures, right? It's recommended not to use it in bio-naive. So I do think that tofacitinib is a good choice there. My first line biologic tends to be vedolizumab. Now, if I used vedolizumab first and they failed it, then if I could get them on tofa, I think that's a reasonable option. There's still some issues with insurance approvals in the US, and oftentimes we're sort of forced to use adalimumab first, which is not a bad drug, but it's, I do think that adalimumab at the dose that it's approved at probably may not be as effective as some of the other choices.
Saurabh, can I ask questions?
Sure.
Yeah. Dr. Sood, that question we are going to address in the case that you have mentioned here. So if that's okay, we can address it during the case. Or if you have any other questions, please go ahead.
I just wanted to say that a very nice presentation, Professor Edward. In India, keeping cost in mind, small molecules have really gotten well. Biologics still, the cost is very high.
Right.
So we are really more interested in learning more about JAK inhibitors. Do you recommend tofacitinib for acute severe steroid refractory ulcerative colitis, because that is one situation where we need to use biologics more often. Second,
yeah, and I think
second is that how long can we really use it? Are there data available of its use even beyond 1 year?
Yeah, I think I'll answer your second question first. I do think, so we have open label extension data now. It isn't fully published, but there have been a lot of abstracts on it, and the paper is being worked on. But in the open label extension trials from the tofacitinib trials, there are now people who have been treated up to 8 years with tofacitinib. And so I think that there may be, what you'll see is, we've already talked about the zoster risk. I think there may be a signal for non-melanoma skin cancers, so things like basal cell, squamous cell. You may have seen that in that longer-term RA study where that issue with the DVTs came out. There have been some press releases about the final results of that study, and there may be a signal for cardiovascular events, and there may be a signal for cancer. When you look at the numbers, it's not a massive signal, but they technically missed their endpoint so that they can't say that they're non-inferior to anti-TNFs with respect to the safety events. So I do think it can be used long-term, but with the caveats that, with the patients got to understand the risk-benefit ratio. So the first question, I think it's going to come up in the case. So I think I'll hold the first question till we do the case.
Okay. So we'll just answer maybe a couple of questions and then switch to the case. So Dr. Jayanti Venkatraman is asking, what will be the top-down preference of biologicals in UC?
My own preference is vedolizumab. I think because it's funny, when vedolizumab first came out, I think everybody thought it was a safety play, but I think it's proven that it's also an efficacy play. It slightly beat adalimumab in the head-to-head trial. And I showed you that one paper, the observational study where it was compared to infliximab, which I thought was pretty thought-provoking. I think one of the reasons why it's a nice choice is that it seems less immunogenic, and so I do think there's a difference in treatment persistence where we've all seen the patient that initially responded to an anti-TNF but then lost response. And sure, that does happen with vedolizumab, but I think it happens less often. That's my preference in a world that doesn't have insurance companies and pharmacy benefit managers. In the real world, what often happens is when we see a patient, we're counseling them about what we want to use, but we say, but we may not be able to get this approved and you may have to use this. And so I think they're all useful drugs. And so if I'm constrained and have to use another one, that's fine. We'll use it. But my preference is vedolizumab. I don't know, Deepak, what do you see in your practice in terms of the insurance landscape and all that?
Yeah, I think to echo Ed's point, for UC, I think my first choice therapy in the outpatient at this point would be vedolizumab if all things are equal, but all things are not equal. So insurance, although I'd say that at least and again, I think this experience varies by the state. Like people in Michigan have said that there's lots of issues with like getting first line access to vedolizumab. I personally have not really experienced much of that, but interestingly on Thursday, we just had Missouri Medicaid have this sort of Russia meeting where they're suddenly trying to put vedolizumab as second line therapy, maybe even after tofacitinib, which I thought was crazy. But yeah, I mean, I would choose vedolizumab as first line for UC, except maybe, and which I'm interested in Ed's opinion on this, except maybe in the patient with very significant arthralgias, especially that are not large joints. So like small joint arthralgias, back pain, that seems to be correlating with disease activity. I think those kind of situations I probably wouldn't go with vedo as first line. Large joint tends to parallel more of the colonic inflammation
I still might try it and kind of see what it does with the arthralgia.
Yeah, Dr.
Totally agree.
Dr. Desai, do you guys have any experience with Vido now that it's in India? Have you guys used it much?
Just started.
Yeah.
So initially, before it was approved, we have used it, and now we are just starting to use it because the Vido cost is little higher than the other ones. So like what Professor Edward said, that other factor come into play here. Other thing is that the recent AGA and other guidelines suggest that okay, all are equal, but Vido probably would be useful in the failure of first-line anti-TNF. So we follow as that as of now.
Okay. Okay. All right. So we could start the case, and then then we can take some questions a little later if that's okay. So Atul, we have Dr. Atul Gavande, who is our gastroenterologist with us. So we'll be discussing the first case. So Atul, you've shared the screen. Can you unmute yourself, please?
Yeah, sure.
Yeah. So we can move forward. I think we can just show us some data in India just for our American audience, I guess. Atul, can you move slides? Okay. Yeah. So yeah. So just to share with you guys, in the last 2-3 years, we have seen about 551 IBD patients in India. 493 were ulcerative colitis, 58 were Crohn. So basically, 90% of what we see is ulcerative colitis, and just about 10-11% Crohn's. I don't know if the other national speakers have had similar experiences. So next. And looking at ulcerative colitis, again, average age of 44, most males, again, next Crohn's. Again, same thing with Crohn's, almost 2/3 were male and 1/3 were females. Again, similar middle age, 40 plus minus 16 years, next. And then we do have a lot of ongoing trials. So I believe probably the mirikizumab and some of these drugs have already been, we've sort of been involved in those trials at our center. We have currently 10
Yeah,
trials.
almost everything. We are almost mirikizumab, itralizumab, itrasimod, almost all the molecules we are trying. We had finished the trial of filgotinib also.
Yeah. So anyway, let's move forward with the case now. Yeah.
Thank you, Dr. Saurabh. Am I audible?
Yes. Thank you.
Yeah. So we proceed with the case. A 60-year-old male presented with history of loose motions mixed with blood since 20 days with frequency of 15 to 20 times a day, with no history of fever or pain in abdomen, and patient did not have any comorbidity. Patient underwent colonoscopy outside, which was suggestive of ulcerative colitis, pancolitis with query pseudomembranous colitis. So these are the picture of colonoscopy which was done outside, and we can here see that there's a multiple pseudopolyps. So they have deep ulcers, and there is the yellowish white membrane over the mucosa suggestive of the pseudomembranous colitis. So histopathology report was suggestive of ulcerative colitis. Patient received steroid outside, and his prior labs were that his hemoglobin was 3.7 gram per deciliter, for which he received blood transfusion, and then he was referred to Midas for further management. So at admission with us, his frequency was 10 to 15 motions a day mixed with blood. On examination, he was conscious oriented with a pulse of 72 per minute. BP was 130/80, per abdomen was soft, not non-tender. CVS, RS, and CNS examinations were within normal limits. Now, coming to the labs, his HB was 8.5 with low albumin, with a low sodium and potassium. He had hypomagnesemia with a high level of CRP, that is 97 milligram per liter. He was negative for Clostridium difficile toxin assay, and his X-ray abdomen did not show any features of dilated colon or perforation. So coming to the questions.
All right. So the first question, Atul, next. So what's looking at all this? What do you think is the diagnosis? This is just straightforward acute severe ulcerative colitis? Is this just pure C. diff? Is it C. diff superimposed on ulcerative colitis? What do you feel based on this finding? Any takers?
I think I think it's at a minimum, I think it's probably the last. It's definitely, it would be hard to imagine that just C. diff alone could make the colon look like that. So I think it's probably UC, and maybe there's a C. diff superimposed upon that. But certainly this is a patient who's very, very ill. And, we need to, these are always big diagnostic dilemmas. You need to treat the C. diff, but this is somebody where I would just think that we've got some IBD going on as well.
Yeah. Yeah, so one thing was the patient had a severe anemia and bloody bowel movements. Now, how often do you see that with C. diff? Do you see that at all? I don't think,
I really don't think of C. diff by itself causing bloody bowel movements.
Right.
Yes.
Yeah, that's what. So that was our Dr. Sood. What do you think?
Yeah, patient has anemia and the albumin is low. Maybe the disease has been there for a longer time than the symptoms are suggestive. Otherwise, if you really think of C. diff as the primary disease or superimposed on ulcerative colitis, it looks a little awkward that the first presentation of UC with C. diff is a bit unusual. C. diff, we know that IBD patients are more prone to get C. diff infection, but generally it happens in people who are exposed to the treatment rather than as a first presentation. But we can't ignore the fact that anemia is marked. I agree that underlying UC with C. diff seems to be the more likely possibility, and I would like to go for PCR and stool GDH, and I will repeat GDH toxin and maybe PCR again.
Right.
Know that you won't miss out on C. diff.
Yeah, and Dr. Desai.
So basically, we know that if the patient has underlying ulcerative colitis and patient has watery diarrhea and high WBC count, that would more favor C. diff rather than only ulcerative colitis.
Right. Dr. Rao, do you end up seeing some of these? Do they end up coming to you or just the GI colleagues first? Go. I think you're mute, sorry, Dr. Rao. Yeah.
It's very interesting, actually. Very clinically, actually, as per the colonoscopy findings, it looks like C. diff superimposed on UC. Yes, we do see these patients, actually. And the presentation because I really don't know, whether this patient was diagnosed earlier or this is the first ever time this patient presented to you.
Yeah.
It's unusual to have this sort of a mucosal picture without any symptoms before, and the patient presented for the first ever time here.
Yeah, no, that's true. I think it was perplexing for us that it was such a short history.
The pancolitis, which advanced mucosal disease, and the patient has not presented earlier for any symptoms and presented. Very, very unusual.
Yeah. Atul, next. So just that brought to us. Now, it looked like probably the patient had C. diff, but the C. diff toxin assay is negative. Now, I was used to the PCR. I think in the West, PCR is taken off clearly. But the toxin assay doesn't seem to be that sensitive. Any thoughts on that?
Yeah, so I would say, so actually, interestingly, just to add the perspective that I think to Saurabh that, yeah, like Mayo is used to doing the PCR, but then at our current hospital, actually, we have a C. diff expert who's from ID and who actually suggests or is sort of inclined against using a PCR and goes by the toxin assay. But I think to echo everybody here, even if the assay is negative, I would be hard pressed to believe that there is no superimposed C. diff here.
Right.
And if PCR is not available, I'd probably treat it anyway as if the patient has C. diff along with other treatments.
Yeah, agree. Yeah, and any other causes of pseudomembranous colitis that you see apart from C. diff? Anyone seen other causes? Yeah.
Well, you can occasionally see ischemia look like pseudomembranes, and occasionally like certain of the hemorrhagic E. coli infections can cause pseudomembranous, but it's, it's vast majority are going to be C. diff.
Yeah. Okay. Until next. Yeah, I think we can skip this. We see it. Move forward. Yeah. Next. Let's 4 more questions. So now say, we're looking at this as acute severe ulcerative colitis with C. diff. Any preference of IV? What sort of steroid formulation? Hydrocortisone, methylprednisolone. I know there are some preferences around.
At Mayo, we use methylprednisolone. Typically, the starting doses, depending on who you talk to, is either 40 or 60 milligrams daily. Whether or not you should give that in divided doses also, I think, depends on the consultant. I think once a day, 60 milligrams is what I would go with. But there is a little bit of variation. Everyone uses methylprednisolone, but the dose and whether to give it in divided doses, there are some differences.
Right. So, Dr. Su, Dr. Desai, do you prefer hydrocortisone, methylprednisolone? Any?
Yes, we use hydrocortisone, 300 to 400 milligram every day.
Right.
Yeah. Same here, although accepting that methylprednisolone has lower sodium retention and potassium wasting effect, so probably methylprednisolone, but we are used to using hydrocortisone.
Right.
Yeah, Dr. Loftus, any thoughts on why methylprednisolone over hydrocortisone? Because we have been using hydrocortisone. Sorry.
I don't have any. I think it's just one of those things that has been passed down, and we've been using methylprednisolone since I've been here for 29 years, and we've, including fellowship, and we've always used methylprednisolone. So it's one of those just things that's been handed down.
Right. Yeah, I think there was some data to suggest slight preference for methylpred, but again, not like clearly demonstrated. Okay, next question. So what's your style of monitoring these patients? Say this patient comes in, now you start treatment. How frequently and how would you monitor?
Well, I want to also mention, it was mentioned in the chat by somebody. The other thing to think about here is cytomegalovirus. So typically when these patients get admitted, within 24 to 48 hours of admission, we like to do a flex sig and obtain biopsies and ask the pathologist to specifically look for CMV inclusions, because that might change our therapy. Admittedly, it's a much rarer co-infection than C. diff. It's probably 1/10 as common as C. diff as a co-infection, but it's just something to consider.
Yeah. Dr. Su, do you see CMV much in India?
Yes, we do see, but if I talk of this patient, this is his first presentation. And
already have causes. Yeah.
This is his first presentation, and he has not been exposed to steroids or other immunosuppressive therapies earlier. So I will say it's not a very strong possibility, but in any way, all patients with acute flare, we do take biopsies and we do look for CMV.
Yeah. Okay. All right. Next question, Atul. You can keep going. Yeah.
So he was started with injection hydrocortisone, 100 mg QID with IV albumin, oral vancomycin in the dose of 250 milligram QID, IV metronidazole, and correction of hypokalemia. So there was a partial improvement on day 5th. His stool frequency was decreased to 8 to 10 times a day, again mixed with the blood. Patient had persistent hypokalemia and hypomagnesemia despite being correction, and CRP has decreased on 5th day from 97 to 33 milligram per liter.
Okay. So again, now this is partial improvement. We're not getting where we need to be now. You're 5 days out. So would you want to label them as steroid failure now? This is a little obscure because this patient has maybe C. diff as well. How many days do you wait before calling them as quote unquote steroid failures? And what else do you consider when you're calling them or labeling them?
So I think we typically are doing 5 days before labeling them, but you may want to be doing things in advance of that. So like if you are thinking about rescue therapy with, say, infliximab, you may want to in advance do things like check the quantiferon, or do some type of TB testing, or get your hepatitis viral serologies out of the way before moving on to salvage therapy.
Yeah. Now, just a question. Now, this was that's tough case because there's C. diff that you're suspecting. How comfortable are we starting infliximab in this scenario? Because already you're immunosuppressed, but I mean, you're already using steroids. Patient's not improving. Because will we potentially cause more harm if we use infliximab, or not really? It's probably hard.
Not really, because I think they're on good coverage, right? This patient is on relatively high doses of oral vancomycin and plus getting metronidazole, so I'm a little less concerned that I'm going to make things worse. I still think it's in the mix as an option.
Right. Yeah. Okay. So yeah, next question. So now, if we say, this is a steroid failure, any preference, cyclosporin or infliximab, use sequential therapy? Dr. Sood, I think in India it's cheaper, right? Like using cyclosporin would be cheaper, but we are always inclined towards infliximab. Any thoughts?
Yes, sir, we have used and we have reported our experience with both cyclosporin and infliximab.
Yes.
But of late, we know that both are equally effective and both are equally safe. But patients who have been previously on azathioprine, they may not be very good candidates for cyclosporin. But this patient has not been exposed to any drug, so we have a choice. It's open. But somehow, I think we all use more infliximab rather than cyclosporin. Maybe the trough levels of cyclosporin are difficult to maintain, or whatever reasons, and we have to bridge it with the azathioprine for a long time. But whatever reason, I think in India, infliximab use is more common than cyclosporin, though we all say that both are equally effective. Devendra, I would like to know his opinion. If you ask me personally, we are using more infliximab nowadays.
Yes, infliximab is more used than cyclosporin, and probably because of two reasons. One is they tend to have low magnesium, and like this patient had low magnesium, low cholesterol level, and if this patient, we have not been able to bring up that, so that automatically shifts the preference to infliximab more than cyclosporin.
Yeah. Okay.
We've used cyclosporin in patients, those who were not affording, with good result. But then two caveats: neurotoxicity and nephrotoxicity has to be monitored and get their cholesterol lipid profile before starting cyclosporin.
Yeah. Oh, thank you.
Saurabh, I guess just one thing to add would be the albumin, as was pointed out at the beginning when the patient was admitted. So in terms of factoring that in terms of the dosing of the infliximab itself, would be very curious to kind of hear your thoughts and other panelists' thoughts.
Right. Yeah, that was my next question, and I think we can allude to that next question. Yeah. So thoughts on using infliximab and dosing that based on levels in these cases. So as Deepak pointed out, the albumin was low, and obviously this patient has like 10, 20 bowel movements a day. So I'd just be curious to know, Dr. Loftus, how would you approach it, and how do you would you give 10 milligrams a kg and then check trough level at a certain point? What would be your thought? Yeah.
Well, you certainly could. It's been surprisingly difficult to show in any even observational studies that using 10 milligrams or using dose stacking, meaning giving the second dose earlier than normal, it's actually been surprisingly difficult to show in any study that actually improves outcomes. I'm just playing the devil's advocate here. But yeah, for sure, with this hypoalbuminemia, you would be thinking about, if you didn't give 10 the first time, you would, if you're not seeing a quick response, the next dose, you're probably gonna A, give early, and B, give a higher dose. And hopefully if you have access to drug levels, you would check those and use that to make treatment decisions. We're lucky because our own lab does the levels, so our turnaround time is 36 to 48 hours. So that's something we can do in not real time, but pretty close. So that can be helpful.
Yeah. Dr. Desai, what's the status of drug levels in India? Or Dr. Sood? Yeah.
So we have been routinely doing drug level, and we are trying to monitor proactively. So far, we did not have any guidelines for acute severe ulcerative colitis, but now we have some guideline as to the level that we can expect after 2 weeks. And if the normal level that we try to maintain is about between 3 and 7 for the reactive monitoring. But in ulcerative colitis, a level of less than 16.5 at 2 weeks probably is predictive of steroid failure and colectomy.
Yeah. Okay. All right. Next move.
So So this was the X-ray abdomen on the day 6, which show this dilated transverse colon with a diameter of 9 centimeter. There is thickening in the wall of the colon with a thumb imprint sign.
Okay.
So we decided to do sigmoidoscopy on that day. So on sigmoidoscopy, we can see here there is complete loss of vascular pattern with there's multiple pseudopolyps. There are deep ulcers with the yellowish white membrane over the mucosa. His UCEI score was 6 and a biopsy was taken.
Nice. All right. So next, so I think we went through that CMV, which is what we did the biopsies for. Okay, next. So Dr. G.V. Rao, would you, as a surgeon looking at this patient?
See, actually, it's very difficult. A 60-year-old presenting with massive GI bleed with hemoglobin dropped to 3 grams for the first ever time, and with a picture which shows extensive mucosal disease. I personally, though it is very difficult to convince the patient for surgery and the primary this thing actually, because it's presented to the first ever time. But I personally feel the response to any medical therapy, even on long term, could not be so beneficial. I mean, I may not concur with a lot of people, but a 60-year-old with this sort of a disease, with this sort of a mucosal, I personally believe that I think once and this sort of a picture on colonoscopy, once the patient stabilizes, I think patient should be given an option of surgery.
Yes. Dr. Sood, would you recommend surgery, try medical therapy a little longer, biologics?
No, here the colon is definitely dilated. Actually, we don't know what happened to his heart rate or fever or was he very toxic, because X-ray shows it's a dilated colon. I suppose he had features of toxic megacolon. If you say it's toxic megacolon, the max we can wait is a day or two with steroids. Otherwise, we hand over to surgeons. But see, looking at this X-ray, I would like to call surgeons the same day.
Yeah. No, thank you. Yeah, we did obtain surgical consult. Dr. Yogesh Bang is here. But the patient was, abdomen was soft, vitals were totally stable. But then, of course, the colon X-ray did not look good. We do have Dr. Ravi Kiran. If I'm not mistaken, you are at Cleveland Clinic and Columbia as an IBD surgeon. I will allow him to talk if he's here from his experience. But anyway, Dr. Desai, what are your thoughts now?
Saurabh?
Yeah.
Saurabh, can you show the histology?
Yes,
before,
we can do that.
I think before you go ahead, because the histology was obtained before this.
Right. We can show the histology. Yeah. Next. We can get to the question later. Next, histology. Okay, so the patient was not inclined to surgery, but yeah. Dr. R. Ravi is here. I'll allow Dr. R. Ravi, if you're, I did promote him. Okay, I guess he's a pathologist who has seen the patient. So yeah, go ahead, Atul, you can just describe what was seen.
Yeah, so we have talked with our pathologist, and he said that there was crypt distortion with the crypt branching, which are suggestive of the inflammatory bowel disease, and there are also crypt abscess with mucodepletion and the regenerative activity. But along with that, there is also a fibrinous exudate is seen. So in the left side, you can see here there's a volcano type of pattern of exudate, so which are typical of the pseudomembranous colitis. So this patient has features of IBD superimposed on pseudomembranous colitis.
Okay, no, thank you. So just going back to the question now. Yeah. Timing for surgery, I think we did allude to that a little bit. Dr. Rao, what sort of surgery would you perform in this scenario?
Yeah, it's a very good question. Actually, it all depends on where it is with this sort of a patient is presenting actually. Mm-hmm. Sending to a tertiary referral center, I think with adequate exposure to minimally invasive surgery, yeah, I think we have had good experience with laparoscopic surgery with this sort of a thing, even though the colon is slightly dilated. Initially, be apprehensive about doing this laparoscopically, but with more expertise that is being gained, and then also there's a lot of literature to show that laparoscopically it can be tackled now. I think laparoscopic subtotal colectomy with ileostomy would be a first preference for this patient. But for any reason it is not available, I think even an open surgery is as good as laparoscopy wherever facilities are not available.
Yeah. So I believe there was some evidence in toxic megacolon and C. diff. Just an ileostomy was performed and nothing else. Would you just do that, or would you remove the colon at the same time?
But this patient actually looks, abdomen is soft. Patient looks quite stable. I think.
Be happy.
I think that would again increase one more session of surgery for this.
Yeah.
Patient, that would be a better option.
Okay, thank you. Yeah. All right, next. So patient was a little less inclined. Yeah, go ahead. Sorry, Atul. Yeah.
Okay. So patient was advised about the surgery and he has been told about that the necessity of the surgery at this time, but patient not inclined for surgery. So we decided to continue with the medical management with IV steroids, oral vancomycin, and the IV metronidazole.
Okay, next.
Yeah. So this part we have already discussed. So on day 7, his vitals were stable and the stool frequency was still 8 times a day, again mixed with the blood. And on 8th day, the patient had distension of abdomen, but there are without any signs of peritonitis, without any hypotension. But on abdominal percussion, the liver dullness was lost. So in view of this loss of liver dullness, we've done the X-ray abdomen, which suggests the gas under diaphragm, which suggestive of the perforation.
All right. Okay.
So patient.
If you want to talk about.
I was involved. Good evening, everyone.
Bang is our surgeon, GI surgeon.
Yeah, I'm the part of a surgical team from Midas Hospital. So this patient I was seeing from day 6 when he had developed that toxic megacolon. In the morning of day 7, also patient had vitals which were stable, abdomen was soft. There was no tenderness. In the morning of 8th day of this steroid even, that day also patient was stable. But in the evening when I was leaving, and these are the times when you leave from the hospital, these are the times when these patients perforate. So that's what happened with this patient. About the time when I was leaving, we had clinically something unusual. We found something unusual in the abdomen. Abdomen was getting a bit tense. Patient still had a pulse rate of around 85, 86. BP was still stable. And the liver dullness had lost. So we got an X-ray urgently and which showed the perforation. So we took the patient for laparotomy within an hour. Intra-op, there was a mild free fluid as it was just an acute perforation. The perforation was at cecum, as well as there was one more perforation which we found at the sigmoid colon. So I did subtotal colectomy and ileostomy and the sigmoid colon end which was there. I brought that out as a mucus fistula at the lower end of the wound, and we gave a good lavage, and we did a colectomy with ileostomy and mucus fistula of the sigmoid colon because it was an inflamed colon. So I didn't want to leave that stump inside and cause any trouble in the future surgery.
Yeah, thank you. Atul.
Yeah. So the colectomy specimen shows the ulceration, basal plasmacytosis, crypt destruction, suggestive of the inflammatory bowel disease.
Okay. All right.
That's very good, Yogesh. Actually, what you did was absolutely perfect. We leave a long stump of the rectum part of the sigmoid. We don't want to mess up the thing because the subsequent dissection should be good. Because any acute dissection during this phase involving the rectum or the upper rectum would involve a lot of difficulty subsequently, and also we tend to do a lot of damage. Perfect decision, actually, Yogesh. Actually, what you've done is perfect, leaving a long segment of the thing which can be subsequently managed medically and subsequently tackled surgically.
No, thank you. So there's some questions on the case here, and by the audience, you can just address it. Dr. Sudhir Vuyuru is asking, do you consider CT before going for surgery? Well, I guess.
So we have a perforation straightforward diagnosed on an X-ray. There is no need of a CT scan for such patients. It is going to waste our 2 or 3 hours of time by shifting the patient to a CT and then getting him back into the OT. So we shifted this patient immediately for surgery as soon as we found a gas in the diaphragm.
Yeah.
In this clinical scenario, there is no need of a CT when we have a toxic megacolon and now a gas in the diaphragm.
Right. And there's
Rob, one point I wanted to make to answer Dr. Sood's question from earlier. There was a lot of buzz at BDW this year about using high-dose tofacitinib as a rescue therapy for acute severe colitis.
Yes.
And so this was based, Peter Higgins gave a talk on this during a symposium, and he referenced this paper that's just recently online in CGH. And they used 10 milligrams TID, so higher than the BID dose, TID for 3 days. Mm-hmm. And they would anticoagulate all of the patients. And you could argue that since this patient has acute severe colitis, they should be anticoagulated anyway, just because they have a thrombotic risk. But anyway, and their results, again, observational, but their results look reasonably good. And so there's been a lot of talk, at least after the meeting, about whether or not we should be doing this. I think, different centers are taking up. I know Deepak has just his own anecdotal experience that maybe he could share.
Yeah.
Sorry, go ahead.
The prolonged duration of tofacitinib in a patient who is infected, would it matter the management?
Yeah, I think for this particular patient, I'm not sure I would have used it, but I just wanted to answer the question from before because it is related to this whole scenario. But I agree, in this particular patient with the whole C. diff issue, it made it a little bit more problematic.
Yeah.
So to, I think, add, I would say in this kind of a patient, this patient and this sort of a patient who's never been experienced or has never seen a prior biologic, I think to echo everyone's point, I would still go with infliximab rescue. Specifically, Peter Higgins' study focused on patients who were already exposed to an anti-TNF, because it also matches up with the labeling in the US that now FDA has recommended use of tofacitinib after one anti-TNF, at least after one anti-TNF exposure. So I think, so we had a similar patient actually, because this week I was on the inpatient service and we had a patient show up like that who was previously exposed to Humira, and then in a flare, and then we started her on the 10 TID regimen, and after about 5 doses did show a dramatic turnaround in terms of the number of bowel movements, disappearance of blood from the stool. So, and again, it's early days. She's in fact still in the hospital. So we'll have to see sort of the long-term sort of progress of this. And obviously this was the very first patient. So, I don't want to make too much out of N of 1 experience at the moment.
Yeah. Dr. Sukrit Sood is asking, was it a good idea to do a flex-sig with potentially toxic megacolon? I think, definitely no full colonoscopy. But if you do it gently with CO2, I suppose to see if there is CMV or so, I guess it's okay. Would you guys have done otherwise? Just not touch him at all?
I don't, because I think I would have gotten the CMV biopsies at the initial index scope, and so I don't know.
Yeah. Okay. And then role of IV albumin, yeah, I don't know. I guess it's low, so probably will help with third spacing. Any thoughts?
Albumin is multifactorial. Sorry.
Probably will anti-inflammatory effect, I suppose. Yeah.
Anti-inflammatory,
Yeah. Okay. And then whether patient was put on heparin prophylaxis, I have to go and see actually if we do it. But I think the active issue was also active GI bleed with severe anemia, which is what the patient came with. Would we still go ahead with, I know there's a thromboembolism risk here, just to weigh between risk of bleeding versus anticoagulation. Any thoughts?
There were actually old studies looking at the safety of giving heparin in patients with acute severe colitis, and ironically, almost nobody has increased bleeding. In fact, some people have decreased bleeding with heparin, and so I think heparin is very safe to give in the acute severe colitis setting.
Right. There's another question Dr. Ravindra is asking. Acute severe ulcerative colitis patient, if the patient is steroid unresponsive and not previously immunized for hepatitis B, can we go ahead with infliximab? I guess if you're HBsAg negative, I suppose you can. Okay.
Yeah, I think if there's no evidence of chronic B infection, I think you can go ahead and give it.
Yeah. Any role of FMT in this scenario? No.
Yes. This patient was very severe disease, and then he had dilated colon. So he is not the right patient. Otherwise, had the disease been little less severe, and there wasn't any dilated colon. In the beginning, one could have considered FMT. I was thinking whether to mention that or not. But he has been a very acute severe. If you say acute severe steroid refractory ulcerative colitis, such a sick patient may not really benefit from FMT.
Right. Okay. So, and Dr. Sudhir Buyuru is saying, why not acute exacerbation of colonic Crohn's? Just looked like severe UC, I suppose. Any thoughts?
I think it's always hard in the fulminant setting to differentiate the two, because we know that with fulminant colitis you can get transmural inflammation, you can get deep ulcers, and so it's always difficult in this scenario.
Right. Okay. All right. I think we can go ahead with Deepak's presentation now. It's a little late in the day, so Deepak, do you want to go ahead with sharing your slides? We'll have.
Yogesh can show the specimen picture. Most of them will get convinced. The decision. Actually, there'll be so much of this thing on the colon. I mean,
yeah, it's just severe colitis, I guess. So this was an emergency surgery. Otherwise, we would probably have had pictures of the case. Okay. Deepak, can you share your screen, Deepak? Yeah.
Yep.
Okay. Great.
Okay. All right. So the second talk on this is the management of Crohn's disease in 2021. Again, I want to start by thanking both Dr. Shrikant Mukherjee as well as Saurabh for this invitation to present on Crohn's disease in 2021. These are my financial disclosures. So I want to start with sort of the impact slide for why this talk and why really we are talking about positioning of therapies, when to treat. Crohn's disease, as we all know on this webinar, is a transmural disease, has been shown to have progression of disease over time if not treated or if not treated adequately. The progression as shown here can be either stricturing disease or fistulizing disease with abscess, eventually leading to surgery. So worldwide, I mean, biologics are often started somewhat late in the disease when they've already had some degree of progression of disease. So increasingly, we are trying to see, can we sort of treat it earlier in the window of opportunity before damage occurs? And certainly there's more and more data about early treatment and better response rates. And again, I'm happy to answer questions related to that, since of course there's a lot of literature and I've not necessarily reviewed all of them here in the slides. So the overview of the talk today is FDA-approved biologics in Crohn's disease. Biosimilars, I touched upon briefly, mainly since there are biosimilars available in India for treatment of the disease. Comparisons between and positioning of therapies in Crohn's disease. or at least an attempt towards that. And then very briefly about the treat to target paradigm specific to Crohn's disease. And then I have just a brief slide on tofacitinib for Crohn's disease, which seems topical since there are a few questions related to that in the chat box about any clinical data outside of the actual trials. So I'll start with the FDA-approved biologics. This is sort of the timeline for approval of biologics and biosimilars in Crohn's disease in the United States, slightly different in Europe and, of course, India. We started with approval for Remicade, the originator molecule being infliximab in 1998, when interestingly I was still in high school. And then Humira or adalimumab, which is the originator molecule, came out in 2007. Certolizumab, marketed as Cimzia in 2008. And then subsequently Entyvio or vedolizumab in 2014, by which time I was with Saurabh in the GI fellowship. And then Stelara or Ustekinumab came out in 2016 while I was in the IBD fellowship under Ed, who's speaking today. And then interestingly, Ed and I actually wrote an article sort of about positioning and sort of some of the data around side effects and the trial data of Ustekinumab when it came out in 2016. 2016 was also the time when the first biosimilar Inflectra, which is the molecule CTP13, was approved for use as a biosimilar infliximab in the United States. The approval for that somewhat similar in Europe under Remesma, and then interestingly, as I found out, South Korea actually had approved it as a biosimilar even earlier, back in 2012 itself. And subsequently, there have been, I think, approvals for the infliximab biosimilar in India, potentially around the 2014 to 16 time period. And, I'd be interested in the experience from the panelists during the Q&A. So starting with the mechanism of action, biologics and small molecules, some of this I included for the benefit of, if any, sort of the early career gastroenterologists or trainees who may be on the call and less familiar with the molecules outside of the expert panel. So starting with the TNF-alpha inhibitors, Crohn's disease tends to exhibit a Th1 phenotype compared to Th2 phenotype with ulcerative colitis. The approved biologics for Crohn's disease in the United States include infliximab, adalimumab, and certolizumab under the TNF-alpha inhibitor group. So I've shown some of these key studies under each of these TNF-alpha inhibitors, again, more for the benefit of early career investigators who may be on the call, because I always feel like before you move forward in a field, you really should know the history of the field, including specific to the molecules. So infliximab started with initial study by Steph Targan that published in New England Journal of Medicine of the molecule CA2. This was followed by the ACCENT-1 trial led by Steve Hanauer. And then subsequently, Bruce Sands did the ACCENT-2 trial that published in the New England Journal of Medicine. Now, this is a key study because this, as of today, and I'm happy to be corrected, but as of today, this is still the only actual randomized trial that actually looks for the efficacy of infliximab in visualizing Crohn's disease. Most of the molecules have all shown data from post-hoc analysis of the originator trial. And this is part of the reason why, beyond, of course, clinical experience, why infliximab is often used as a drug of choice for internal penetrating and perianal visualizing disease. Now, the fourth key study that I feel all the trainees should know is the study SONIC, which was led by Jean-Fred Colombel, and at least in my view, is probably, at least in the last 15 years, sort of the single most important study in Crohn's disease that has directly impacted clinical practice. And at least I tend to think of this almost every time I'm in clinic and faced with a relatively refractory patient. Switching to adalimumab, and as you've probably noted in the top right-hand corner, I'm also showing the structure of these molecules just to sort of show the difference. Again, something to just keep in mind that infliximab and adalimumab broadly act the same way. However, they do have structural differences, and adalimumab being more humanized compared to a greater mouse component in infliximab, which also translates to lesser risk of immunogenicity, especially when used in monotherapy. So adalimumab, classic 1 trial led by Steve Hanauer, This was followed by the classic TRUE trial for maintenance of adalimumab for Crohn's disease. And then the CHARM trial, really even more important for adalimumab, especially for trainees to know, because this really sort of structured the trial similar to how we use it in real life practice, comparing 40 every other week to 40 weekly to placebo, and showed the response and remission rates, short-term and long-term. Certolizumab is sort of the third molecule in the category. Top right-hand corner shows the structure, that it's different from adalimumab and infliximab. It's a pegylated molecule, which is important because this will not go through the placenta. In some ways, may be a drug of choice if you have a pregnant woman with Crohn's disease. While, of course, you can treat with any of the available biologics, and they're all equally safe. Phase 2 trial led by Stefan Schreiber, and then further studies include the PRECISE-1 led by Bill Sanborn and the PRECISE-2 led by Stefan Schreiber, which were phase 3 trials for certolizumab. Next, switching to the next mechanism of action, which is the anti-integrin. Mainly, we have one right now FDA approved in this treatment category, which is vedolizumab, marketed as Entyvio, which is which inhibits the alpha-4 beta-7 integrin interactions with the MAdCAM1 and the VCAM1, as shown here in sort of the bottom of the slide. So vedolizumab, the initial phase 2 data came when it was called the MLN0002 by Brian Fagan as a phase 2 study in CGH. This was followed by the key phase 3 trial, Gemini 2, specific to Crohn's disease, run by Bill Sanborn. And then also of importance is this third study, in my view, which was run by Bruce Sands, which specifically looks at vedolizumab efficacy in patients who failed an initial TNF alpha antagonist. Now, this to some extent mirrors regular life, where if you've used an anti-TNF first and then used vedolizumab, how may this work out? Now, this study especially failed to reach its primary endpoint, which was clinical remission at week 6. However, it did show clinical response at week 6 based on a 100-point drop in the Crohn's disease activity index. And more importantly, did meet a secondary endpoint of clinical remission at week 10, as well as, of course, clinical response at week 10. Now, why is this important? Now, this is important because if you have first-line anti-TNF therapy followed by vedolizumab, this sort of gives you somewhat of a timeline and not to get discouraged if your patient is not in remission by week 6, and you may want to give the patient some more time on therapy before you call this a treatment failure. So this is one of the key studies in my view. Now, the next mechanism of action, which is from what I've understood from discussions with Saurabh and other Indian gastroenterologists, that is not available currently, but something that may be available down the line, is inhibition of the interleukin 12-23 pathway. Now, Ustekinumab, marketed as Stelara, is what is currently available in the United States and Europe. And this inhibits the P40 subunit as shown here, that thus inhibits the downstream signaling from both IL-12 and IL-23. Now, as shown in some of the studies highlighted in UC by Ed, there are IL-23 inhibitors that are in the process of trials and may be available in the next 1 to 3 years, which specifically inhibit the P19 subunit, which then means that it is specifically inhibiting the IL-23 downstream signaling, but not IL-12. And broadly shown to be as effective, if not in some instances more effective, especially in the RA patients. So we'll be very curious to see how this space grows. Ustekinumab, again, structure shown in the top right-hand corner. The initial phase 2A study was by Bill Sanborn, shown here in gastroenterology. This was followed by the phase 2B study, which was called the Certify study. And this specifically was in patients with refractory Crohn's disease, who had failed an initial anti-TNF. Now, this study interestingly also failed to meet its primary endpoint, which was of clinical remission at week 6, but did show clinical response at week 6 and met clinical remission at week 22, which was pre-specified secondary endpoint in the trial. And in some ways, certain echoes similar to vedolizumab in patients who've had first-line anti-TNF therapy. Now, the key phase 3 trial was led by Brian Fagan, including the Unity 1, Unity 2, and IM Unity sub-studies within the phase 3 program, showing that Ustekinumab works for induction and maintenance for moderate to severe Crohn's disease. So that's sort of the FDA-approved categories in the United States. I'm briefly touching upon biosimilars in Crohn's disease, mainly because of the biosimilar availability in India, and of course for Inflectra that's available in the US. Now, a biosimilar, by definition, is a biological medicine which is highly similar to another biological medicine already licensed for use and has been shown not to have any clinically meaningful differences from the reference product in terms of quality, safety, and efficacy. Most biosimilar approvals have occurred through equivalence. You have one indication, let's say infliximab in ankylosing spondylitis. The companies that make the biosimilars do the pharmacokinetic trials and show the chemical equivalency, and that leads to a broader approval across the various diseases that it's broadly approved for. So I wanted to highlight some definitions that some of the people in the audience may hear about time to time. So the cartoon on the right shows the originator molecule as shown here. Sorry, I'm just trying to move the grid video. As shown here, a switch is movement from an originator to a biosimilar molecule versus a reverse switch is going from the biosimilar back to the originator. Cross switch is if you are on a biosimilar and you switch to another biosimilar. So there is now data for switching from an originator to a biosimilar, which is what happens for the most part in real life, or I should say in daily practice. So this data came from the North Switch study, which published in Lancet in 2017. As the name suggests, was done in Norway. The study design was as follows. You had patients on originator infliximab, stable, and then were for at least 6 months, and they were randomized 1:1 to either originator or switching over to CTP13, which, as you recall, had been called Inflectra in the United States starting in 2016. And the primary endpoint in this non-inferiority trial, they chose a margin of 15%, assuming a 30% worsening of the primary endpoint, which was disease worsening at week 52. So what did the data look like? The data was across the various indications for infliximab, and obviously the number of Crohn's disease patients and ulcerative colitis patients was somewhat limited, but the larger trial included the various indications. The way to interpret this figure is that to the left, if the lines were not intersecting 0 and were completely to the left, then that would favor the infliximab originator, whereas if it's completely to the right, again, not intersecting 0, that would favor CTP13. Across the indications, they all straddled 0. Hence, this trial met its non-inferiority endpoint and led to wider acceptance of biosimilars after the North Switch study. There have actually been other trials also since, but I didn't want to cover all of those for the sake of time. The one thing to be aware of in biosimilars in IBD, I think at this point we are all accepting of biosimilars and we believe it works. But really that should be a conversation that you should have with your patient, ideally in a shared communication mode. Because there's something called as a nocebo effect, which is basically that if you don't discuss this with your patient and patients get switched, maybe through your approval, or get substituted, which means the patient went on a biosimilar and neither the treating clinician nor the patient were aware, and they find this out down the line, there is the risk of a nocebo effect, which is that the negative expectations then can lead to certain lowering of patients' reported well-being and even sense of adverse symptoms, which can then lead to lowered patient adherence and negative effect on treatment outcomes. So I do believe the biosimilars work. It is just that we should probably fully disclose to the patient at the start of treatment that they're starting on a biosimilar, or if because of insurance reasons or other practical reasons, patient is on the originator and gets switched over to a biosimilar at some point. Next, switching gears to the comparison between therapies and positioning of therapies. The definitions of remission in Crohn's disease have been largely evolving over time. We started with clinical remission several years ago and have subsequently switched over to biological remission and more recently endoscopic remission as part of treat to target. with strict definitions such as healing of ulcers or an SES-CD score of anywhere from like 0 to 3. And then potentially in the future, there may be other targets such as histological remission or radiological remission. So treatment strategies for Crohn's disease are driven largely, in my view, by the risk for progression of disease. So patients can be divided broadly into low risk versus high risk. Low risk patients, as an example shown here, are older at the onset of initial diagnosis, in this case greater than 30, tend to have limited anatomical involvement, no perianal or severe rectal disease. The ulcers tend to be superficial and have not yet undergone surgery, and nor do they have a stricturing or penetrating phenotype. The opposite of this would suggest a risk of high risk for rapid progression, as shown here. Some of this is nicely outlined in this paper by Bill Sanborn in Gastroenterology in 2014. And there's actually also been a subsequent publication on prognostication, high versus low risk, by the IOIBD that published in the Gut Journal. So the way I look at treatment for Crohn's disease is based on stratifying risk of progression, which is the disease severity. So there are some patients, just to acknowledge, who are at low risk of progression, which in the view of the AGA and in my general experience are fairly rare. I mean, they're less than 1 in 5 patients. This would be a patient who has limited anatomic disease, purely inflammatory phenotype, not stricturing or penetrating at the time you see the patient, and has disease limited ideally in a single segment, usually the ileum and or the right colon, and have minimal to no symptoms, meaning they have not lost weight, they are not deeply anemic, they are not having significant extraintestinal manifestations, they're not having significant impact on quality of life. Such a patient may be induced into remission using budesonide 9 milligrams per day, and then potentially subsequently maintained on remission with azathioprine as an option. Now, in someone with mild disease with no to minimal symptoms, even if they have pancolonic Crohn's disease, meaning a mild pancolonic Crohn's disease, one can consider treatment with sulfasalazine, which in my view, sort of probably the only situation where I personally would be comfortable based on my training, treating somebody with a 5-ASA, because otherwise 5-ASA and sulfasalazine does not have data for efficacy in Crohn's disease outside of this very limited presentation. So now beyond that, so sort of your usual patient with Crohn's disease, moderate to severe, who's at risk of progression, what does the data look like for first-line induction pharmacotherapy in a biologically naive patient, has never seen a prior biologic? I have it in the headline itself, and as Ed said in the discussion, very cautious about applying network meta-analysis to practice. Ideally, we want to see real trials comparing agents. So in this network and meta-analysis by Siddharth Singh in Elementary Pharmacology 2018, looking at the bio-naive patients, what we see here is across the approved biologics for Crohn's disease, certolizumab certainly does somewhat poorly with a lack of a positive effect size compared to the rest, and the strongest effect size was for infliximab and adalimumab. Same publication, next looking at what happens after first-line infliximab therapy if you were to use the next set of therapies. Here, there was a positive effect size seen for adalimumab and ustekinumab, but not vedolizumab, suggesting that vedolizumab after an initial anti-TNF therapy, at least in this network meta-analysis, may not perform the same as the other 2 agents. Let's look at more data, because I know vedolizumab is available for use in India, but not ustekinumab at the moment. So I was interested in showing you more data comparing vedolizumab against an anti-TNF. Now, this was a very interesting study as part of the Victory Consortium. This particular publication came out in 2020, led by Matthew Bohm out of Indiana University and senior author Parambi Dulai out of UCSD. They looked at clinical remission, steroid-free clinical remission, and endoscopic remission. They split the data between those who are anti-TNF naive. In other words, vedolizumab first line versus infliximab first line versus a subcutaneous anti-TNF first line versus anti-TNF exposed, which means vedolizumab second line versus infliximab second line versus a second line subcutaneous anti-TNF. Now, the key take-home message for me in this was, in a first-line therapy scenario, vedolizumab, you could argue here based on the data shown in bold, performs better than a subcutaneous anti-TNF as first-line therapy for Crohn's disease, for clinical remission and steroid-free clinical remission, and no difference for endoscopic remission, and performs at least non-inferior to infliximab for the same scenarios in the anti-TNF naive. Now this changes a little bit once you've been exposed to one anti-TNF. Infliximab is probably better than vedolizumab as a second-line therapy if you have a patient who's already exposed to a first anti-TNF, such as, let's say, adalimumab. While, again, there's no difference between vedolizumab or a subcutaneous anti-TNF in someone who's been exposed to a first anti-TNF, let's say infliximab. Additionally, beyond effectiveness, looking at safety, no significant differences were seen in the risk of serious infections or serious adverse events for vedolizumab compared to the anti-TNFs. But vedolizumab did show a lower risk of non-infectious serious adverse events in terms of splitting the serious adverse events between infectious and non-infectious. It did show lower non-infectious serious adverse events with vedolizumab, showing that maybe there's a tiny incremental value in terms of safety for vedolizumab when compared to an anti-TNF in this scenario, even if used as second-line therapy. Another interesting finding from this study was that they looked at disease duration, meaning when was the treatment started in terms of the duration of disease the patient already had when they went on to either vedolizumab or anti-TNF. So what you would see here, if you can see my cursor, is that patients who had a short duration of disease seem to do well on vedolizumab, which again, the red line here denotes 1. Anything to the right of that favors vedolizumab, anything to the left of that favors an anti-TNF. So patients who were short duration disease started on vedolizumab seem to do better compared to anti-TNFs, versus people with longer duration of disease, potentially 5 or more, maybe using an anti-TNF over vedolizumab might make more sense. More data on use of first-line vedolizumab versus first-line anti-TNF is emerging from the EVOLVE study. Now, the EVOLVE study, similar to the Victory Consortium, is a retrospective effort. This involves centers out of United States, Canada, and Israel. They try to come up with a simple rule for who might be a patient who might benefit from first-line vedolizumab. And if you can see here, the adjusted Cox hazard ratios are all positive in favor of vedolizumab. And these all are for median time to remission and the likelihood of that. So the sort of the simplified version of the simplified rule is that if you broadly look at it, patients who have active disease when you see them, but are not sick enough that they've had to visit the ED or the ER prior to the index visit, and have no existing stricturing disease, penetrating disease, or perianal disease, seem to be the kind of patients who likely are going to do well on vedolizumab as first-line therapy. So this further from the same EVOLVE group shows in the bottom right a graph where clear separation of time to remission exists. In fact, shorter median time to clinical remission for vedolizumab compared to anti-TNF, with a adjusted hazard ratios in favor of vedolizumab in this particular age group. The simple rule being that they have active disease but have not been sick enough to go to the ER and do not have penetrating disease prior to the index visit with you as a clinician, which in this study was a large number of patients. And of course, the data may vary depending on the center you're talking about and any kind of referral bias. But this is the kind of patient who likely do well on first-line vedolizumab therapy. In this particular trial, the duration of disease was not a factor, unlike in the prior study that I shared with you from the Victory Consortium. The other interesting question they asked from EVOLVE is, let's say you started vedolizumab as first-line therapy. What if you did anti-TNF after that in the patient who fails first-line vedolizumab therapy? Does the anti-TNF work just as well as first-line anti-TNF therapy? So this is data from the EVOLVE cohort at 3 months and 6 months. Gray bars are first-line anti-TNF, orange bars are second-line anti-TNF. Broadly, you'll see definitely second-line anti-TNF therapy doesn't do any worse. In fact, there may even be suggestions for better cumulative rates of clinical remission in the second-line anti-TNF therapy compared to first-line in those who failed and a vedolizumab first-line therapy. Now, again, this is retrospective, so I would take it with a pinch of salt. But again, it's interesting that there's data suggesting that there are a subset of patients who can have first-line vedolizumab therapy. And then if among them some fail vedolizumab first line, you could consider second-line anti-TNF without any drop in the effectiveness rate. So what about first-line ustekinumab versus first-line adalimumab? And this is data hot of the DDW, which was a CView study presented by Dr. Bruce Sands. This was a multi-center randomized blinded active control study where patients were randomized either to ustekinumab 6 milligrams per kilogram, which as shown here in the bottom reflects how we treat them clinically based on the weight, or plus placebo injections, or loading dose of adalimumab plus placebo IV. And this design was repeated in a treat-through pattern. Corticosteroid tapering was done if applicable starting at week 8 or 16. The primary endpoint was clinical remission defined as a Crohn's disease activity index of less than 150 at week 52. And in this, there was really, while ustekinumab was numerically higher, there was no statistical difference between the two categories and very little to separate them. For the major secondary endpoint of endoscopic remission, defined as a short endoscopic severity of Crohn's disease of 0 to 2 at week 52, again, there was really no difference between adalimumab and ustekinumab, and in fact, maybe numerically slightly higher for adalimumab, meeting the major secondary endpoint, but no statistical difference. For the adverse events, they were numerically lower in the ustekinumab group, similar to our understanding from clinical practice that it is likely overall a safer agent compared to adalimumab. And opportunistic infections were reported in the adalimumab group, including active pulmonary tuberculosis, which may be relevant to the Indian setting, and disseminated herpes zoster and a paracoccidoides infection in the ustekinumab age group. One event of non-melanoma skin cancer, mainly a basal cell carcinoma, was reported in the adalimumab group, and no deaths were reported. So my key take-home message from this, now that sort of depends on where you're practicing. For me, I interpreted it as ustekinumab is as good as adalimumab, so I would continue to use ustekinumab as one of my first-line options for Crohn's disease. The other way to interpret it is also that adalimumab was no worse than ustekinumab, so more data to suggest that if you have adalimumab as your primary agent that's available, it seems to work as good as ustekinumab from an effectiveness standpoint, but from a safety perspective, definitely there are more cases, including of tuberculosis. So again, the positioning of agents, you have to keep in context the country. So this brings us to sort of the slide on positioning. I look at it mainly in terms of effectiveness has already been proven from all these agents in phase 3 trials. I then look at safety and then also importantly access. Now, there are some questions about the cost of care, but I cannot fully comment on that, and hopefully we can comment on that in the Q&A, as I'm not fully aware of the cost of each of these agents in India, and some of our experts in the panel would know this way more than I do. So prevention is the best way to avoid complications, including vaccines upfront, baseline screening, including tuberculosis, careful history, incorporating IBD checklists in your practice. Anti-TNFs, we know, have an increased risk of infections, common infections as well as opportunistic ones. Vedolizumab, overall a very safe agent, can show transient LFT elevation. There may be arthralgia is more common in that treatment group, non-infectious pharyngitis, and a possible numerically higher evidence for C. diff in the trial, although I have not seen that in my clinical practice. Anti-IL-23 agents, while not available in India currently, also are very safe, no black box warnings. And then IL-23 agents or blockers in the future may be somewhat similar. JAK inhibitors, to comment, again, they are not approved for Crohn's disease in the United States or Europe. Tofacitinib is only one currently available in the market, although Rinvoq is now available, or upadacitinib is now approved for rheumatoid arthritis and potentially available in the US for off-label usage. This does have several side effects, including increase in lipids, viral infection risk, mainly zoster, non-melanoma skin cancer, as I heard Ed also mention earlier, There is risk of venous thromboembolism that has been shown in RA patients, although I have not necessarily seen that in my practice. And again, I would be interested in hearing the expert panel. Our real world cohort, again, that has been published on safety in clinical gastroenterology and hepatology with about a 6 months to 1 year follow-up did not show that. There's likely a cardiovascular risk, especially in older patients if used with tofacitinib. The malignancy risk, perhaps a signal for lung cancer, may be there in the RA cohort. And again, we need to see the final full publication to comment on that. S1P agonists, I'm going to skip over here, are not approved for Crohn's disease, but are approved for UC, and Ed kind of went over those. So in terms of how I think of this currently, in terms of the safety pyramid, this is how I look at it. Vedolizumab is sort of the top of the pyramid as the safest, followed by anti-TNF monotherapy, followed by thiopurines or tofacitinib as the next agent, and combination therapy of thiopurine with an anti-TNF at the bottom. But keep in mind that inadequate treatment is also an adverse event. So this is the safety pyramid, but you have to sort of look at the patient and treat them appropriate for the disease. Steroids are a band-aid, and here it's at the bottom inside a red box to show that you can use that acutely induce remission, treat symptoms, but it's not a long-term treatment strategy, and ideally you should find a steroid-sparing mechanism for long-term treatment. The speculative safety pyramid of tomorrow could include the S1P agonists and the selective JAK inhibitors, as well as the anti-IL-23 inhibitors. But as I said, this is purely speculative, and more to come on this. Very briefly on treat to target, blood-based biomarkers are available, mainly C-reactive protein sort of came up in the case, and I'm not going to cover that in detail. Stool-based biomarkers as well as radiological tools. Stool-based biomarker that I mainly use is fecal calprotectin, which has fairly good performance in terms of association with endoscopic disease activity, better for ulcerative colitis than Crohn's, but also in Crohn's, fairly impressive performance. And a cutoff of 150 microgram per gram in the STRIDE-2 consensus that has been recently published in gastroenterology may be consistent with endoscopic healing for use in clinical practice. The STRIDE-2 consensus looked at biomarkers as an intermediate target in UC and Crohn's disease. Radiological tools briefly include CT enterography, MR enterography, and bowel ultrasound. I'm not going into the details of any of those, and I'm happy to take questions on the panel. I do think in Crohn's disease, they have a complementary role because 70% of patients with Crohn's disease have some form of small bowel involvement, but about 30 to 35%, depending on the study, are restricted to the small bowel. And you may not always be able to assess the small bowel because there's a stricture at the IC valve, and colonoscope is unable to traverse through that, or there's a stricture at the anastomosis if the patient has had a prior surgery, and again is unable to assess the small bowel. Additionally, the patients themselves don't really enjoy the burden of bowel preparation on a regular basis for sequential colonoscopies. And again, I often, in my practice, may interchange between radiology and colonoscopy for small bowel Crohn's disease, mainly to reduce the burden for the patient. And sometimes the patient themselves will express that they would rather undergo the radiological exam rather than colonoscopy, as long as we have good data available from that. And then finally, it may miss disease because Crohn's disease has been known to skip the terminal ileum, or in fact be intramural, meaning the radiological scan shows active disease, but that same segment on a colonoscopy or biopsies are negative. For those interested, I have listed 2 references at the bottom of the slide that I was involved in as part of the small bowel interest group in Mayo Clinic when I was a fellow that kind of go into both of these scenarios. I'm going to just show the slide and skip that. It's mainly also useful for prognostication, high versus low risk Crohn's disease. And then I want to spend the last few minutes on the CALM study that has actually now given us good quality RCT data for a treat to target design, at least for Crohn's disease. So this particular study, which was a CALM study led by Jean-Fred Colombel and which published in Lancet in 2017, looks at 2 arms, randomized clinical management driven by symptoms, mainly the CDAI, as well as steroid usage, and a tight control arm, which was driven by not only this, but plus biomarker usage, fecal calprotectin and C-reactive protein. And then the treatment itself was using adalimumab as shown here, with escalation depending on which arm you are. And then the clinical management itself is as shown here, whereas tight control used the clinical scores plus biomarker scores as shown here, with the cutoffs as shown here. And so you could potentially use these cutoffs even in your clinical practice potentially. So this study showed that the primary endpoint of the study, which was at week 48 after randomization, looked at endoscopic remission, which was defined as a Crohn's disease endoscopic index of severity of less than 4 and with no deep ulcerations. And clearly 46% of the patients on tight control achieved this compared to 30% with standard clinical management. So this RCT has now given practical information for how we can do tight control. This also met several secondary endpoints, including deep remission, biologic remission, as well as mucosal healing. So how can we do this? This is an example as shown here as a cartoon. Patient has active disease at baseline. We risk stratify as shown earlier. Are they at low risk for progression or high risk for progression? And let's say they're high risk for progression. We start them on a biologic as available and accessible. 3 months in, look for biomarker response. 6 months in, repeat a colonoscopy. Ideally, if we can achieve a target of no patient symptoms, no positive biomarker surrogate, and no mucosal ulceration as defined in CALM, then we know that the patient has in fact achieved deep remission. And then you can continue the treatment and reassess this in 1 to 2 years. But in the alternate scenario that they have not achieved these, especially the endoscopic endpoint, you go back to optimizing the drug using therapeutic drug monitoring. And then depending on whether this is an immunogenic failure or a primary therapeutic failure, you can either switch within class or switch out to a different mechanism of action. And then the last couple of slides, I have one slide on off-label therapies for Crohn's disease. So this is clinical data we generated out of the TROPIC consortium for using off-label tofacitinib for Crohn's disease. And this is published, first author Mark Fenster and a group including myself as senior author. We published in the Clinical Gastroenterology Hepatology in 2020 in October. The key take-home message on this is figure B, which shows that whether you failed one biologic or 2 or more biologics, we had fairly reasonable clinical response rates at week 8 or 16, as well as endoscopic remission rates within the 1 year of follow-up and endoscopic reassessment of these patients. So these were a fairly refractory group where we tried to rescue these patients using tofacitinib as often a second, third, or even a fourth line strategy. So this is some of the clinical data that currently exists for tofacitinib use in Crohn's disease, not in the bio-naive, but in someone who's bio-exposed. So to finally stop, last slide, what is my practice today? So for patients who do not have a fistula, regardless of age group, I often try to start them on vedolizumab or ustekinumab as first-line therapy, especially in the older onset patients or who have comorbid cancer or infection. Vedolizumab or ustekinumab is especially attractive in terms of low risk of infections. Now, you do have the rare patient who has very limited disease, as we spoke about before, restricted to one segment with minimal or no symptoms, where you could induce them on budesonide and potentially maintained on azathioprine for maintenance. Now, in terms of access, of course, I have not focused here on azathioprine, but of course, if that's the only molecule available for access, then certainly one could consider azathioprine for maintenance of remission. Although I do still feel personally that that is inferior to using any of the currently existing biologics for patients who are at a high risk for progression. Definitely the patient with internal penetrating disease of fistulae, perianal fistulizing disease, or have extensive extraintestinal manifestations, mainly small joint arthralgias, sacroiliitis, uveitis, iritis, extensive oral ulcerations, a coexisting pyoderma gangrenosum, I would primarily go for infliximab with coexisting immunomodulator therapy with it. Now, if patient did start on an anti-TNF first and had a secondary loss of response because of immunogenicity, let's say they started on a sub-Q anti-TNF, in my practice, I would probably switch out to ustekinumab. However, if that's not available, one could consider switching out to infliximab or vedolizumab, where I may favor those over vedolizumab after a primary anti-TNF exposure based on also some of the data I showed you. Now, if somebody is on infliximab and there's a primary loss of response, I would switch out of class to either ustekinumab or vedolizumab. I prefer ustekinumab, but if you have vedolizumab available, I think we can definitely try that. Now, if you've already been on infliximab and you have antibodies to infliximab, again, I would probably support switching over to either ustekinumab or vedolizumab rather than switching over to a subcutaneous anti-TNF as a second-line option. So most of this is supported by data. Some of this is, of course, my personal bias. And then in pregnancy, any monoclonal antibody is okay. I tend to treat through pregnancy. I think we have good data from the piano registry now for safety. I'm happy to discuss that if there are questions. Methotrexate, whether the patient is on either male or female, should stop it for at least 3 months prior to conception. Tofacitinib, for the female patient, should stop it for at least a month, if not longer, before conception, because I think there's still not enough data to talk about safety. However, that position may change in the future once we have more data. But at the moment, I don't think there's enough data to support the idea of continuing tofacitinib during pregnancy. And with that, I'll stop. Here's my email as well as my Twitter account. If you have questions that remain even after the Q&A session today, I'm happy to take more questions. Thank you.
Great. Okay, thank you, Deepak. That was exhaustive and fantastic. Very nice overview on all the biologics. It's really evolved over the last 2-3 years. I think we were, vedolizumab, I remember, came like, 3 years ago, and then now you have ustekinumab, tofacitinib, all these smaller molecules. So it's getting more and more complicated, and it's nice to simplify and have an algorithm at the end, as you showed. But yeah, we're getting into a more personalized approach, more for IBD now. So we have, I promise I won't stretch it more than 10-20 minutes from here, because I know it's a little late in the day on Sunday for everyone. But we will try and address as many questions as we can from the audience. So just to sort of go, up
Deepak,
here.
Can I ask one question? Deepak?
Sure.
Deepak, it was a wonderful presentation. I must compliment you for that. I have 2 questions. One, when you start biologics, how long? And number 2, you combined it with azathioprine for the long term. Secondly, if the patient has clinical remission, but if the fecal calprotectin is higher, what do you do in a patient with Crohn's disease?
Sure. So start off, thank you definitely for the compliment. And so first question of how long I would treat someone with a biologic. And I think you're trying to also get at the question of potential role for de-escalation at some point.
Yeah.
So I think it's a great question, probably, and I would love to get Ed's thoughts and of course all the members of the expert panel on this. But personally, in my practice, I think if you are definitely on a combination therapy with, let's say, infliximab and azathioprine, I think the sonic data is good for 6 months up to a year. But beyond a year, I would be somewhat hesitant unless in very specific scenarios, like this is someone who's, and again, I think there's always, you have to be careful extrapolating trial data to real life, because there's a lot of cherry picking of patients. So you have to be careful. Like if I have a patient who's never undergone surgery, but had deep ulcers in the ileum, I followed the sonic algorithm, put them on combination therapy, and then I've had treat to target follow-up and have shown that the ulcers have healed and they're doing really well. I would be inclined towards stopping the azathioprine and just continuing infliximab monotherapy in my practice. Now, that answer may be somewhat different in a different context, depending on the cost of care in a different setting. But that's where I would go, because the risk of lymphoma, at least in the study using the VA cohort, suggested that it really goes up after 2 years of treatment with azathioprine. So trying to kind of get it under that is somewhat of the strategy here. Now, that answer may be different, of course, if you're talking of a patient who's already has had 3 surgeries. And if you sort of let the disease come back, you're looking at a 4th surgery. Now, in that patient, I think that is a careful discussion you have with the patient. Like they have to see a dermatologist every 6 months. I mean, to look for skin cancers, especially if they have a lighter complexion. They have a job that makes them, be out in the sunlight a lot. They're not like a computer professional. Not that computer professionals don't see sunlight, but it's sort of what I mean by that. So I think it's a careful discussion with the patient. What is their how much are they willing to take, what amount of risk versus benefit of fourth surgery? I think so. It's a careful discussion. So I think if you're on 2 drugs, I think it's easy to drop one. If you are on just 1 drug, I think I worry, because most of the studies coming out of Eastern Europe they had to do this to some extent initially because of their guidelines, but around 2 years out, up to half the patients tend to flare. So, and even in my practice, where patients somehow, without telling me, have stopped drugs, I've actually seen that, without even being intentional, where half the patients are flaring at the end of 1 year. And also the issue that if you restart the medication, there is no guarantee that you'll be able to recapture the remission in the same way as before. And in fact, I've even seen that with Entyvio for that matter, even though it's not supposed to be immunogenic. I can't fully explain it. So that's, I think, your first question. Your second question was calprotectin use. So I think, the CALM study, for example, I think that would make the suggestion that it's not just clinical symptom, but also going for biomarker remission, because there's good data to suggest, let's say, especially in the first 12 weeks, if you have a significant drop in biomarker, you can certainly associate that with the likelihood of remission out at 1 year. So I think it depends on the findings of the fecal calprotectin. Like if you're talking about, let's say, like 160 or 200 even, not crossing 250, I may not be so inclined to be super aggressive about, kind of trying to aggressively change therapy. But if we are talking of clinically they feel great, but the calprotectin value is something like 500. So then, again, it's a discussion. I mean, I have changed, especially during COVID, where it was harder to do endoscopies. I have changed therapies and escalated therapies based on biomarkers, while I might somewhat more depend on the endoscopy if in a real pinch.
Yeah. Well, thank you, Deepak. There are a lot of questions, so we'll try to get them done quickly. Tina Aswani Om Prakash, who's a very patient advocate. She's asking, how about TOFA for Crohn's in India? And thank you for sharing your recent data about the effectiveness of TOFA, especially even failed interferon, infliximab patients. So Dr. Desai and Dr. Sood, do you use TOFA much for Crohn's now that it's cheaper, pretty effective compared to biologics? I know there's some side effect risk, but what are your thoughts? Yeah.
I have not used.
You have not used?
Yeah.
Okay. Dr. Sood, sorry, I think you're mute. Yeah. All right. Dr. Sood, I think you're mute, so if you may unmute.
Sorry, I said that we have used TOFA for ulcerative colitis, but not for Crohn's.
Okay. Okay. All right. There's some other questions here. Dr. Shrikant Gopi is asking, practically, which patients with terminal ileal involvement would be selected for surgery as a first line in Crohn's disease? Dr. Rao, do you do it at your center? Would you consider limited ileal disease patients as primary surgery, or do they end up getting biologics up front?
Yeah, I mean, at the outset, I think congratulate Deepak with a fantastic presentation. Actually, he's given us a lot of inputs. Thank you, Deepak. Actually, that was a great presentation. And it really gives surgeons a different perspective. But anyway, actually, compared to ulcerative colitis, we as surgeons treat more a radiological disease than an endoscopic disease or a mucosal disease or a histologic disease. Vis-a-vis when I'm comparing it with ulcerative colitis. A localized IC, especially in India, a stricturing disease, I would rather treat laparoscopically than consider these patients for any long term. One will have treated the disease, two will have a proper histology of the thing, especially disease localized to IC area. I would prefer surgery compared to medications?
Yeah, I think it's relevant in the Indian context of the costs of the medications. Now, the other issue that we always encounter is the biologics and tuberculosis risk. Dr. Sood, Dr. Desai, what's been your experience with tuberculosis reactivation in the Indian subcontinent with all the treatment, the biologics? Yeah.
Yes, I think we have reported our experience. Devendra and myself and Dr. Puri were there in that article. It's with anti-TNF agents, it's really high. The tuberculosis reactivation is somewhere around 8 to 12%. So it's a very important issue. But what I've observed of late, last 3 or 4 years, or for that matter, I think even it goes even a little beyond that, the tuberculosis is less often seen now. For the last 3 years, I would say specifically, we are not seeing many patients with reactivation. I would like to know Devendra's opinion also, whether he also feels that in the last 3 years there is a less number, but our own publication showed it is very high.
Yeah. Okay. Thank you.
I agree, actually. I agree that now we are seeing less tuberculosis. I don't know whether it is because of the patient's nutrition improvement or so, but clearly less incidence of tuberculosis. And as earlier, we had 8% for Infliximab and 8 to 12% for adalimumab.
Great. Thank you.
Ajit, do you agree that the incidence of relook surgery, I mean the second surgery or the third surgery, has dramatically come down now compared to what we used to see 4 or 5 years back?
Yeah.
I think patients who are going for surgery, initially we used to think these patients come back with multiple surgeries and all. But now the incidence of second, third surgery is dramatically come down after all these medications.
Yeah, no, definitely.
Yes, I agree with you when you said that stricturing disease in the terminal ileum is a definite indication for surgery, and we should consider surgery in a localized ileal disease, even without stricture. The patients who can't afford long treatment, it's not a bad option. A limited ileal disease, even without stricture, inflammatory disease, we should give a chance to surgeons. I think we cede ground in that matter. I'm becoming more pro surgery for limited ileal disease.
Yeah. Well, especially in our context, when the ileal and cecal involvement is there, we're debating between tuberculosis. Well, that's a different debate, I suppose, completely, which is going to be another case, but we'll skip that today.
Saurabh, I also wanted to mention, there's also now data from the LYRIC trial, which was done out of Europe to sort of support the idea of, and again, ideally I should have had that in my slide set. That's one study I missed. But yeah, LYRIC trial has support for primary ileocystectomy as an option.
Right.
And again, limited data right now, it's I think up to a year out so far, like in terms of follow-up on the trial, but they've still shown fairly good rates of quality of life up to a year out from the primary ileocystectomy. So there's certainly data suggestive for that, because again, with stricturing Crohn's disease, none of these treatments are going to reverse a stricture that we have at this point. And of course, if there's any diagnostic confusion, I think, again, going for surgery, especially for the first time when you've never had surgery before, while understanding that, again, you should be aggressive about follow-up, ideally like doing like a follow-up colonoscopy, maybe 6 months out from the surgery, to look at the anastomosis, risk of recurrence, and then trying to like factor in, when you should start therapy, if the patient's an active smoker, and other such kind of fine details.
Yeah, there's another question. Post-surgery management of Crohn's. What are the thoughts? Still treat with infliximab, follow up, wait for ulcers to develop?
I think if it's the, by the way, Deepak, wonderful talk. That was great. I think if it's the first resection, you don't necessarily have to start anti-TNFs or any biologic post-op. You could bring them back in 6 to 9 months for a colonoscopy, assess for endoscopic recurrence, and then make your decision. But if it's the second surgery or later, then I'd be a little bit more aggressive there.
Right. Okay.
Yeah, I think there's also some data starting to emerge on the sort of the margin of the lesion, meaning the margin of the resected specimen. There's, I think now at least 2 or 3 studies now showing, again, I mean, from different centers, that if the margin is positive for active disease, there may be an association with risk of recurrence, among one of the things. Although, this was not shown in the old studies out of Cleveland Clinic. Some of the recent studies are suggesting that, again, that may be something you will want to factor in when you're thinking of when to start therapy and if to start therapy.
Yeah. There are some questions by Dr. Subhamoy Das. He's a pediatric gastroenterologist, I see. So he has some questions. Very early onset IBD. I don't think we see that much in our practice because you're for adults. Any role of stem cell transplantation is what he's asking. Also, anakinra in this with very early onset IBD with CARD8 mutation. Anybody seen this? Any experience? Dr. Loftus, yeah.
We haven't done sort of stem cell transplant. It depends on the workup. If a patient has a monogenic disease, then there is a role for this. And monogenic disease very early onset or even late onset also. So it depends on the and there are some patients where there is a family history or a different presentation or not responding to the biologics. One has to suspect history of consanguinity. These are some of the pointers which suggest there may be a monogenic disease, and one needs to do extensive workup for such cases. There it has a role.
Right.
Yeah, I agree. For adult GIs, I don't think we think about this as much as our pediatric colleagues, but I know my pediatric colleague, Mike Stevens here, has a panel that he sends out for looking for monogenic causes. And I think we think of it in some of our younger patients who have recurrent infections or just something unusual. And like Professor Sood said, the consanguinity history, which we will occasionally see, it has to be considered, but we're not routinely doing genomic testing in all of our patients, but in those types of patients, we might think about it.
Yeah. And there's some question about isolated colonic Crohn's disease, whether we can use tofacitinib in these patients. Clearly looks off-label, but with Deepak's data, perhaps promising, especially in India. Any thoughts?
Yeah, so, they sort of had us analyze for location of disease. We ourselves kind of thought of this exact same question. We didn't really see a signal, but again, it could be because we are limited by sample size, right? Like we don't have, this is not like a exhaustive number of patients, like numbering the hundreds to look at that signal. Again, we did not use that as first-line therapy because obviously the label in the US that would not, suggest using tofacitinib as first-line therapy even for UC. So certainly in Crohn's, these were all patients who had at least seen one biologic, which was even like the minority. Most had seen 2 or more biologics. So I think it can be used, understanding that, obviously there's several adverse effects that need to be kept in mind, as well as monitoring, like, lipids, risk of zoster. And then certainly you should be, I would probably suggest against using this in an older patient, definitely over the age of 50, there's risk of major adverse cardiac events. So, it's really like in my view, it's really a minority of patients who might benefit from this. I certainly wouldn't suggest using this as first-line therapy for Crohn's.
Okay.
And if you are considering the localized Crohn's disease, why not consider surgery rather than consider off-label drugs?
Right.
Exactly, right. And if it's very mild colonic Crohn's, and I think I mentioned this in the talk, there is that very mild colonic Crohn's patient who might just do fine on sulfasalazine or something like that. Even if it's in more than one segment and surgery is sort of likely to, lose too much bowel.
Dr. Palaniappam Singaram is asking, 17-year-old with ileovesical fistula, distal ileal stricture, low volume fistula, also operated elsewhere 6 months earlier, operated for sigmoid or vesical fistula and recovered. What would be the approach? I think the question really is whether you have a high risk of urinary tract infections if you use, say, anti-TNFs in this scenario, is sort of what he was trying to get at. Would you go ahead
mean,
with biologics? Yeah.
I would. I mean, that's where the best data exists, using infliximab in combination with azathioprine. And you can always, I mean, put them on prophylaxis if such a risk manifests itself. But again, at least in my limited experience so far, these patients do fine. I mean, it's not like they have, because anyway, having stool go through into your urinary bladder itself puts you at risk of urinary tract infection. So if anything, the treatment is likely to try and close that fistula if possible. Although, again, depending on how big the fistula is, this patient may need surgery again, unfortunately. But something to keep in mind.
Okay. Dr. Rajendra Patel is asking, we have patients treated with azathioprine started on Vido. Should we stop azathioprine and use Vido as monotherapy or continue Aza along with Vido? So most of these trials are just monotherapy, right? Yeah.
I mean, I think you can use combination therapy if it's a sicker patient, a higher risk patient. So it's not like you're going to. The downside are the side effects. It's not going to decrease the efficacy of the Vido, but it's the question of whether or not it's necessary. So I think it's probably not necessary in the average patient, but in a high risk patient, I might continue.
Right. Okay.
Right. So I think the risk of immunogenicity with Vido, most studies, including a recent one as part of using like the huge number of patients out of Prometheus labs that it's one of the assays that test for Vido levels. It's around 2%. It's really low compared to infliximab or adalimumab for that matter. And there's an interesting retrospective study done by Ashwinanth Krishnan from MGH, and I think also at Brigham data that suggests it's retrospective that there wasn't really a bang for the buck for adding in like a concomitant immunomodulator. But again, it's retrospective, so take with a huge pinch of salt. And as Ed said, if you have a patient who's had 2 surgeries previously, and this is like their second or third line biologic, and they were actually in remission with these 2 agents, again, a discussion that you may want to continue it rather than stop it. Again, it's a case-by-case basis.
Dr. Prashant Bhandarkar is asking, 35-year-old gentleman with a lump in right iliac fossa, internal enteroenteric fistula, but reasonably good health. Would you consider only budesonide or biologicals are a must? Colonoscopy shows ileocecal ulcers. Well, I guess you need biologics clearly in this patient, and any surgery, I suppose.
Yeah, I don't think the budesonide is going to be enough. Yeah, I think you need a biologic.
Yeah. Okay.
And you honestly may need surgery first. I mean, it may be tough to fix this through biologics, depending on the exact anatomy.
Yeah. So Dr. Amol Vadgaonkar is asking, infliximab versus adalimumab in fistulizing Crohn's disease with controlled anterior abdominal wall abscess. After drainage of abscess, which therapy is better? I suppose infliximab.
Dynamic dosing, you can like really, really get it up there. I mean, it'll be tough to do that with adalimumab, even with weekly dosing.
Okay. Just a couple of questions and we'll wrap up. I know it's getting late in the day. Should Dr. Subhamay Das is asking, should azathioprine be reserved in pediatric Crohn's to prioritize biologics in azathioprine naive state, showing better response? Not sure I follow that. Okay.
I think he's trying to ask if we should use certain biologics as primary therapy rather than azathioprine, given that they seem to work better in the bio-naive, Aza-naive state, right? I think it's probably what I think. I mean, azathioprine, again, I think it goes down to access, cost. I mean, we know from a safety standpoint, yes, Entyvio makes sense. Especially there seems to be increasingly good first-line therapy data to show that Entyvio works well, even in Crohn's, as a first-line therapy. And we know azathioprine and risk of lymphoma, this is like well-described literature, especially young males. I know it's very, 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 very rare, but there's obviously the risk of hepatosplenic T-cell lymphoma.
Yeah. Okay.
If this was me, I would rather be an Entyvio than azathioprine. But and again, I think also you have to factor in cost, access. I think those kind of questions. But in theory, yes, in isolation, just going by data, I'd probably do Entyvio first. But that's just me.
Right. Okay. I think we'll just wrap up, and we'll email the questions to you, Deepak and Dr. Loftus, so we can answer those for the audience. But well, thank you, everyone. I think I'm just going to end it here. So thank you, everyone, for joining in today. It's 9:04, so we should wrap up the session today. But it's been a wonderful session with a lot of Q&As and discussion and excellent talks. And thank you all the chairpersons and panelists for your excellent input, and was very, very helpful. So thank you all for coming here. Next one we have is next Sunday, which is going to be a little more advanced ERCP stuff with hilar strictures, cholangiscopy, altered anatomy ERCP by Dr. Raman Muthusamy from University of California, Los Angeles. And then we have a few more, topics as outlined here on the screen. So thanks, everyone. We'll just close the session, and thanks for coming.
Thanks.
Thanks from my side also.
Thank you.
Thank you.
Thank you.
Okay. Thank you, Dr. Thank you.